Sitting is the new smoking. What's that going on? If you're thin, you can't have BP, you can't have sugar, you can't have cholesterol. Is it true? And already the brain is such a neglected organ. I don't know why. Maybe because people don't use it, I think.
My mother is to introduce to my relatives, friends. My son Anil, he will be a doctor. BP doesn't always cause symptoms. Stroke doesn't mean there's only weakness of hand and legs.
So can you lucidly tell our viewers step by step from the commonest symptom to the less common symptom? I am a disco dancer.
Please don't stop the tablet abruptly. You do a scan, it's normal. It will be normal in TIA. In transient
scan?
ischemic. When you're MBBS, they said, get all check when you're 50 years old. I think it has come down 25, 30 years
Absolutely. First statement of atherosclerosis, it said, atherosclerosis starts in the cradle and ends in the grave. The phones are becoming smarter. I say the human beings are becoming dumber. Does every hospital which has 24/7 emergency stroke ready?
No. The best treatment option available today in worldwide is if you are snoring a lot and in between you give a gap before you get your breath back, that is the severest form. Please go and see your doctor.
If you don't scare the people, they don't take action.
Venous strokes, what we see, it's more common in South India
Really?
for some reason. Yes.
I don't think God will feel bad. Is a season for stroke like people say, chalikala stroke, cold weather is stroke, hot weather no stroke.
I would like to repeat, stroke is treatable, stroke is curable, and stroke is definitely preventable. Each step is important. The awareness is important, treatment is important, at the same time even the rehab is important.
ജ്ഞാനാനന്ദമയം ദേവം നിർമ്മലസ്ഫടികാകൃതിം ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവം ഉപാസ്മഹേ ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവ ഉപാസ്മഹേ ഹയഗ്രീവ ഉപാസ്മഹേ.
Rebooting the brain, powered by PRS Neurosciences. He is today the brand ambassador for stroke in India. Let me introduce you today to our guest, Dr. Anil Ramakrishna. Namaste, everybody. Om Asatoma Sadgamaya Tamasoma Jyotirgamaya Mrityorma Amritam Gamaya. Om Shanti Shanti Shanti. This shloka has a lot of relevance for me and has been a driving force of what I do every single day. As the shloka says, from darkness to light, from ignorance to enlightenment, and from death to immortality. This can be taken in any aspect of your life and see how you can adapt it to become a better human being. So, Rebooting the Brain podcast is one such initiative to create this awareness and education and make this happen. And today on the podcast, I have an extremely important gentleman and a good friend of mine. But before I introduce him, the usual, customary housekeeping things. Please subscribe to our channel. Please press the bell icon. Please share this video widely. You never know who will be the next person who needs our help. And very importantly, as you're watching our videos and finish it, please be generous in your comments. Because that comments may help somebody else get a second lease of life and do something else in their life. So let me introduce you today to our guest, a very senior and well-accomplished neurologist from the city of Bengaluru, Dr. Anil Ramakrishna. Anil, welcome to our podcast. It's such an honor to have you here. We have had a great relationship. Our friendship goes down
Thank you, sir.
many years. Anil is here today to talk about a very important topic. Before I talk about that, you saw the video in the beginning. You saw our favorite cricketer, Sunil Gavaskar. I think my passion for cricket and the love for the sport started because of I used to hear Gavaskar coming to bat. Something is going on in cricket. I think Anil will agree with that.
Definitely.
And we have seen his cover drives, we have seen his on drives. He's not flamboyant like all these Virendra Sehwags and everything else, but
there was
he
no
had
T20 at the time.
exactly.
It's all Test cricket.
But he had a class and so on. His strokes were legendary. So why am I talking about his strokes in this podcast? Because he has been promoting one more stroke after his retirement. He is today the brand ambassador for stroke in India. Now, which stroke? Cover drive stroke? On drive stroke? No. It's a stroke that my board says here, which is called brain attack. Brain attack, stroke, brain attack, heart attack, it's something similar. That means it's a serious problem to the brain. And to talk about that today, we have Dr. Anil Ramakrishna here. Anil, I want to start with a story. This was yesterday's story.
Okay.
I have a young guy, 19-year-old boy, who's in my hospital for neuro rehabilitation for the last couple of weeks. This boy had a stroke. He was getting down the bus. He was traveling from his hometown to study in Bangalore. Suddenly felt giddiness, went to a nearby stroke-ready hospital. They found a floating thrombus in his vertebral artery, one of the arteries in the back of the brain. They thrombolized, they did all of those things, but he still had a complete infarct, deeply unconscious, and he's come to us for rehab. That is bad enough, bad story, 19-year-old boy. Yesterday, what's happened, his father, who's taking care of him, he suddenly stopped speaking in the ward. And he was having some difficulty speaking for a couple of hours. He didn't give much attention. He thought he has not slept, something's happening. And suddenly he stopped speaking. The wife called us, we rushed him down, and he's had a stroke. Can you imagine? And I had told that father and mother when they came in on first day, I want only one patient. Please take care of your health. True. I'm quite sure you agree. Many of our caregivers are taking care of their loved ones. They neglect their own health.
Exactly.
So he had a stroke. Luckily, we caught him on time. He was in the hospital. He's getting better today.
Yeah. Two things there. I think they put any abrupt symptom. I think in the both of them. See, that one thing I have to emphasize, any abrupt neurological symptom, please think of stroke. Okay. As the young boy who was climbing the bus and suddenly had a symptom, the first thing should come to your mind. I think as we go on, we'll discuss the importance of the time there.
Absolutely.
Yeah. And,
absolutely.
His father, he was in the ward and it happened suddenly like this.
So which means the risk factor is there. We're going to come to all of this. There's so much to talk, guys. Don't drop your guard even for a moment, because there's so much of information that we're going to give in this talk today. So stroke has different, meanings for different people. As you understand, already the brain is such a neglected organ, in the sense at the end of the day. I don't know why. Maybe because people don't use it, I think. That's why they're quite casual about it. No brain function test, all other things you can measure, at least high, low, all those.
Another thing is it's varied symptoms,
Yes,
it doesn't cause one symptom.
Exactly.
Like if there's a chest pain, if there's a difficulty in breathing, they know it's coming from the heart or lung.
Correct.
The brain is not like, there's no one symptom.
Absolutely. And sometimes painless.
Yes.
And I think when there's no pain, people don't panic at all.
Most of the brain symptoms are painless. That's one problem. And there are much varied symptoms depending upon the area involved. I think we'll discuss further.
Of course.
So many
but
symptoms.
Before that, what I want to do very specifically is the different kinds of stroke that we understand. So today's stroke, we'll talk about the ischemic stroke, but there are two kinds of stroke that we want the audience to know, and that is the arterial stroke and the venous stroke. So can you tell us just a brief about what an arterial stroke is and venous stroke is, just as a starting, and then we'll go deeper step by step.
It's a basic thing. Like we have a pump in our body, that's a heart, which pumps the blood. So that takes the one blood vessel take the blood to an organ. So every organ needs a blood.
Correct.
Your brain requires blood. One vessel takes it. That's what we call an artery.
Correct.
Once it's gone, the organ utilizes the oxygen, nutrients. The blood has to come back to the heart.
Correct.
And that is brought by the venous. So we have an artery which carries the blood, and we have the vein which carries back the blood to the brain.
Got it.
So if artery is involved, it's an arterial stroke. If the vein is involved, or whether it's an input stroke or an output stroke.
Fantastic. I think that's a very simple and easy way for the public to understand. Thank you for simplifying it, because it is such a mystery, the stroke. To demystify every point, I think, is one of the goals of this podcast. So now that you have said the arterial stroke, we'll start with the arterial stroke, ischemic stroke. What is an ischemic stroke?
I think I would like to just give a small example so that you can understand.
Yes.
So imagine the brain as a garden. with multiple plants and trees in it.
Okay.
So brain has multiple structures inside it.
Okay.
And each plant and tree needs water to survive it.
Absolutely.
The same way, each structure in the brain requires blood. So this is carried from the major vessel, like a big pump. We have a motor, the heart.
Correct.
From there, the big vessel comes out and then it branches out.
Correct.
Okay, like what we do, drip irrigation in the gardens.
Or the Kaveri water supply.
Exactly. So each plant and tree has a separate
Correct.
pipe which gives a blood.
Got it.
So the stroke can develop either if the blockage is in the main vessel
Okay.
or any of the
Smaller.
branches there.
Got it.
So the basic thing in ischemic stroke is the blood vessel carrying the blood to the brain is blocked. There is no blood to the tissue.
Got it.
So like when there is no water to a plant, it dries up, even the blood tissue suffers and we have a symptom.
We got a symptom. That's why it's called ischemia.
Ischemic
What does
stroke.
ischemia actually mean?
Means that it's the brain is devoid of the
blood supply. Got it. That's something similar to happens in the heart when the heart block happens.
Exactly.
It's something similar to that. No? So that got it. So depending, now you're saying that depending on which pipe or which branch gets affected
Yes.
and which area it is supplying, the symptoms are varied.
True.
Now, before we go into symptoms, let us look at risk factors. Now, we had the previous episode of Dr. Vikram Hudet when he told our audience that right from a newborn child till the most elderly, you are at risk for stroke.
Yes.
I still remember when I was doing my MBBS, the Robbins textbook of pathology, the first statement of atherosclerosis, it said, atherosclerosis starts in the cradle and ends in the grave.
Yes.
So what do you want? I mean, now it gets very worrying because there are people who are happy, 40 years, I'm, very peaceful, nothing's going to happen to me. So what do you have to say about the risk factors for a stroke?
Yeah. So when we talk about risk factors, we divide into two. One, the common risk factors and the uncommon risk factors.
Okay.
A modifiable risk factor and a non-modifiable risk factors.
Okay.
So what are these common risk factors? Which we come across in our practice? The most common are uncontrolled diabetes mellitus, high blood sugars, very high blood pressure, high cholesterol, obesity, your increased body mass index. Along with this, if you are a smoker. So these are the risk factors. And if a person has all the three, if he is diabetic, he is obese, he has BP and he is smoking, he has a huge risk to develop a stroke.
He's got all the masalas.
All the masalas to develop the stroke. So each single factor has a risk, but if there's a combination of this, it's a huge risk of developing a stroke.
I can imagine.
With this, there are a few uncommon risks. There may be some genetic factors. There may be some deficiencies of coagulation proteins inside the body. Or if you have a strong family history, you're at a risk of developing a stroke.
Like this boy and his father, as we saw.
There's some...
something going on there.
Yes, in the blood. There's genetic problem, some deficiency of some protein or enzyme which is causing the stroke that we need to evaluate.
Yes, I think so.
It's always first rule out the common things and then go for the uncommon.
But
few things we can modify, few we can't modify.
Correct.
So I think majority can be modified in the sense like diabetes, take care of your blood sugars, see your physician regularly. So good exercise and fitness, risk factor can be reduced. Check your blood pressure regularly. Cholesterols, make sure that you don't have any heart disease. And if you have a family history, make sure that you have periodic checkups with your physician and the neurologist. The risk factor comes. Obviously, if you have a strong genetic predisposition or a family history or advancing age, this which cannot modify it much. The modifiable risk factors, if you focus, I think
you can at least reduce the percentage. You see, there's a common misnomer we hear among our people around us. If you're thin, you can't have BP, you can't have sugar, you can't have cholesterol. Is it true?
No, not at all.
So tell our global audience, because everybody says, hey, I don't get it, I'm very fit, I'm this, I'm that, and they go around and they even neglect because of that. So what is the message for you guys, even for the thin people?
Recent last 10 stroke which I see in my practice, I think 9 were thin and they were not obese, they didn't have...
You also mentioned some of them were even doctors.
Yes, I think recently 3-4 of our doctors or friends developed stroke and they were all thin and fit. So please make sure that you get your regular checkups, at least the risk factors which I enlisted. Look whether you have a diabetes, hypertension, and especially if there's some family history, your brother, your cousin, your father, grandfather suffered from stroke or a heart attack, you have to be a bit more careful. You need more regular checkups and look for.
I've had, sometimes even doctors telling me, if my BP goes up, now I feel something, that's when I check. I mean, patients saying that.
Yes.
And I will tell my patients, listen, I can't look at your face and know your blood sugar.
Yeah.
You have to test it. But why these are all intelligent, educated people doing this?
Yes.
Why is that happening? What is that complacency, or why? How do you shake up people and make them understand
I think
that it's such an easy thing to manage, and yet people don't want to do it?
All you have to do is go check, give your arm and they check the BP and let
You
you
can
know.
do it at home.
Yes. Nowadays everything is available at home.
Exactly.
Okay, you have a digital BP monitor, and you get a digital glucose checking thing. You can do everything. And nowadays, like Swiggy, Zomato, they come home and take your blood. You don't have to go even step out. Okay, just give a call and they're there to check all the risk factors.
Which, by the way, only happens in India.
All you have to do is go check, give your arm and they check the BP and let you
know. You can do it at home.
Yes. So definitely. No, you just are one call or one click away and they can get everything done. So I think the message is that, as you said, don't assume things. Especially now, before, a few decades when your MBBS, they said, get all check when you are 50 years old. I think it has come down 25, 30 years
Absolutely.
now.
Absolutely.
Once you cross that age, make sure that you get at least the basic parameter tested and be careful.
In fact, I will tell you my personal story. See, I have a very strong history of coronary artery disease in our family, on my mother's side. And I was in my third year or fourth year neurosurgical training. You know how those trainings are. It's a madhouse. And there was somebody who wanted some blood to be donated for a child emergency. It was B positive, which was my blood group. So I decided to go. It was St. Martha's Hospital. Somebody called me and I went there. I was post duty, 36 hours. I went there and I lay down and I had not checked my own blood pressure. I lay down there and they checked my blood pressure. Blood pressure was 150, 100. And that's the first time. I maybe checked many years ago. It was okay. And I thought maybe post duty, this, that, but I didn't let go because I knew there was a strong family history. I checked next couple of days. It was consistently high. It was borderline. I wouldn't say it was borderline, but after that, eventually, it went up, and I had to start my medications. So managing it is so important. Checking it, being aware of it is critical. In fact, from then on, I started eating vegetables every day, and even now, my wife says you look like a cow.
I'm very glad you gave this example. Why? Because now we see a lot of young strokes. A lot of young strokes, recently, I think in a couple of months, we have seen, I think more than 10 or 20 were the age of 30s, 40s. And when I talked to them, they first said, doctor, come on, how did I end up having stroke? And guess what? When I check, his lipids are high. HbA1c, which gives an average of 3 months blood sugar, is out of control. His is high. And when I said, I never had a BP, doctor. And when I asked, when did you check? Never checked. And when you check,
this
in the
is amazing.
High,
yes,
they assume. Yeah. The thing is, see, as you rightly said, BP doesn't always cause symptoms.
Absolutely.
Okay. So as some wise men say, pain is good for the body. Symptoms are good for the body. But the problem with this few risk factors like hypertension, blood pressure, they may not always give you the symptoms. They may cause symptoms, but that is the importance of getting the periodic checks to look whether you are at risk of developing a stroke.
At risk. Very true. So you kept using this word assume a couple of times. So I remember doing some management program once, and they said, what is the expansion of assume? I don't know whether you know about it. Assume is ASSUME.
Yes.
It's making an ass of you and me. That's what. So you understand, no? You assume things, I assume this, I assume that, and eventually both of us become an ass. So guys, important, don't become an ass. Don't keep assuming. This is one of the key messages both of us are giving. There is no escape to testing for simple, useful things that can happen.
Mm-hmm.
Now, coming back to what you said about, they should HbA1c average. I have a very interesting explanation for this HbA1c. Before HbA1c came, you have seen these diabetic fellows. 29 days in the month, they eat what they want.
True.
The day before they go to doctor, they'll be very strict. They go the blood test, sugar is normal. And what will wife say? Doctor. Doctor said everything is all right, eat what you want. He wants to eat the vada, bonda, bhaji and all of those things. Why he shows the rubber? So we had to fix those fellows. So we took the average. So then we know that, they can't play these foolish games with us and things
Same
like
thing used to happen with my dad.
Really?
The day he used to go for blood test, he doesn't eat anything. Or he takes a small vegetable or thing and goes. And always his FBS, this thing comes normal because he has not eaten. And he's so intelligent. The previous night also he doesn't talk much. So it comes normal. And when I do HbA1c, it's around 10, 11. That average is high. So don't just go by that one day test of just pricking that I don't have a diabetes. No. So please, that HbA1c I think is important.
I think so. Important. I agree. So the average is critical. And so you are saying, and they have to check, you have to maintain account every day. You can't say that when I'm in a mood, I will eat properly. If I'm not in the mood, It's like filling petrol in the car every day, maintaining a vehicle. This
Vehicle.
also, I think this is
What
more
you-
expensive than a Rolls Royce.
Yes.
You have no spare parts. You're only doing Sunawade Kalsa at the end of the day.
You
and
need to
it's not-
maintain.
you need to maintain all. So now coming to the actual symptoms of stroke, now that they have understood the risk factors, modifiable risk factors, I read recently, actually, one more risk factor. What sitting is the new smoking? What's that going on now?
Yes.
Can you tell us about that?
Yes. That no, I think I missed out telling in the risk factors.
Ah.
Physical inactivity is actually now is
Allah,
one of the biggest
couch
risk
potatoes.
factor for the stroke. Okay, so now you see everything is an online job. Okay, a lot of software engineers.
Everything is in the
they
app
work-
also now.
Everything is in the app. Now, at least before they used to go to the office, sit and then do.
Mm.
Now everything it's available on your mobile.
I think this is the only muscle they are working
at
at.
the mobile and everything.
Uh,
So this physical inactivity actually that will eventually give us to your risk factors. Okay, your BP will go up, your sugar will, you'll put on weight, and that's one of very important. Good, thanks for getting that topic. Physical inactivity is one of this thing. Keeping yourself active, fitness, utmost importance.
See, you know what is interesting? You have this smartphone. The phones are becoming smarter, I say, and the human beings are becoming dumber. It has everything. It has got steps count,
True,
this
true.
count, that count. Today morning I was seeing in a Facebook, you download this app, keep a thumb there, you'll check your blood pressure.
Right.
Everything is available. Yet, we have not seen, have you seen any reduction in the strokes that is coming?
Not at all. Actually, it's increasing.
What does
On
that
the
mean?
contrary, it's increasing.
It is sad, no? People have time to see useless videos, useless things, useful things they don't watch.
Mhm.
It is really terrible. So coming to stroke, what is the, how does a person
They
even
know
know
that-
he has a stroke,
yes.
for example?
Okay, I think I would like to come back again to that slogan there. So please think any acute, I'll underline the word abrupt, sudden neurological symptom is
Yes.
stroke unless proved otherwise.
Bolt out of the blue.
Yes, and stroke can have varied symptoms.
Give us some
Can you believe-
examples.
Sudden onset, like the person is walking and he's not able to see one side. Okay, he cannot see on the left, but he can see everything on the right side. Can be a stroke. Okay, then sudden buzzing sound in the ear and not able to hear on one side. He becomes deaf on one side. Can be a stroke. Okay, and the person suddenly gets confused for few seconds, few minutes, gets back. Can be a symptom of a stroke. The person who's talking normally starts slurring. Okay, or not able to express. Can be a stroke. I would like to tell you a very interesting example.
Sure.
CEO of a big company.
CEO of a big
Yes, a big company had come to the consultation, husband and wife. So wife actually was a CEO. So they were telling the problem she had, like she used to converse on the phone, and suddenly there's a gap, a few minutes, and then she used to continue.
Mm.
So then I explained her, it's coming from the brain, a part of the brain. I think it's switched off. Either there's no blood supply or some extra discharge coming from there. So one of these things are happening. So they were not very impressed. Then I examined in detail. They were highly educated. I said, examination is normal. They said, why are you suspecting anything? So that symptom, that brief pause what she was giving actually was symptom of a stroke.
Are you
When
serious?
evaluated, the vessel was it was constituted to almost 90%. and
Like a
then-
block in the heart, he had a
Yes.
similar block in this neck. vessel.
Exactly, the main vessels that we'll talk
Yeah,
about
yeah,
it.
Sure.
It was one. And any person who's walking normally and suddenly develops imbalance, he cannot walk straight. He
Like the
sways to
drunken
one
person.
side.
Yeah.
Can be a stroke. And very importantly, suddenly the right hand becomes numb. Okay, I can move it, but it's totally numb.
And people start doing all these
yes,
things. They put some
and it
malish
doesn't
finish.
go.
Correct.
Can be a stroke. Can be a stroke.
True.
Okay, and if a person suddenly talks irrelevant stuff for a few and then comes back, can be a symptom. It can be varied symptoms.
So
The key is sudden onset. Any abrupt onset, please consider stroke.
So what I'm understanding from what you're saying is that it's not that if it happens, it remains like that. It can come and go also.
Yes.
And I think that is where and if you start lasting for a few seconds, people may not even give cognizance to that because it's very short or whatever it is. So that comes to my natural next question to you. You are saying these seem to be the early symptoms of stroke or whatever, or warning or whatever you call it. On the other side, there's something that we keep talking about as neuroscientists called TIA.
Yes.
Can you tell us what is TIA, what is early stroke, how do I distinguish between these two
Yes.
and what do I do about that?
TA, the full form is transient ischemic attack.
Okay.
As the word says, it's transient.
Transient.
The symptoms are transient.
Got it.
It's caused by ischemia and
Okay.
it is an attack.
So lack of blood supply, on, off like that.
There is a clot in the blood vessel. For some reasons, it gets dislodged from there
Mhm.
or it gets dissolved because we have the own mechanism in the
Got
body
it, got it.
and they recover. Okay, that can happen. That's called transient ischemic attack.
Got it.
So how to differentiate? That's why the clinical acumen of the doctor is also important. Okay, to consider
Very
that
important.
this is a stroke symptom,
Got it.
and you get an imaging done. Imaging is the very important thing, and imaging is normal. It goes in transient. If it's a stroke, we can definitely find it on the imaging there.
Got it.
This TI is the most important thing.
Why do you say that?
One, it's a warning symptom.
Correct.
Or this TIA can become a complete stroke anytime in the future.
Like a
Within
mild
24
chest
hours,
pain can something similar to
yeah,
that.
it can become catastrophic stroke in the next 24 hours, 48 hours,
Oh.
maybe sometimes a week later. I'll just give an example.
Sure.
A elderly gentleman had come to a consultation. The symptom was while doing a puja, he used to drop that arti tate, whatever. He used to drop it. And so he was worried, but within 10 minutes he recovers. So it has happened a couple of times. Because he recovers completely back, he's not
Nobody
giving
caring.
importance. The kids are in US, UK, so they talk in the evening and they said, no, go and see a doctor. That's why he came to me. I explained him, this can be a TIA, this transient ischemic attack. I told the concept. But yes, the problem is he was totally normal on that particular examination. But somehow, maybe I don't know, it's this thing on my side, he was not convinced, he went back. Okay, he did not do any test imaging. Guess what? 3 days later, he came to a hospital, completely paralyzed, not able to talk, and still now recovering in rehab. So, if at all we had investigated him, we had properly, he would have definitely been a normal person. So, I think the message to everyone is, if you have a weakness of a hand which lasts for few minutes, few seconds, few hours and normal, please go to your doctor and get it checked. Preferably a neurologist or a neuroscience. Please go and check it. That can be a symptom of stroke which can prevent. At the doctors which we were talking about, recently one of the colleagues was working with us. Guess what was his only symptom? So he was going back to his home after his work. The car keys dropped from his hand.
Whoa.
Yes, right hand. And he could not pick up. So he was trying and the hand was not moving.
What?
And within 5 minutes, he could pick up. He sat in the car and suddenly remembered, I keep giving lectures in all these things.
Correct.
So he came back. So we already, the brain structure was normal. There's no stroke inside. But when we evaluated the vessels, I'll tell you the importance of the vessels later.
Yeah.
The one vessel was blocked to the tune of almost 95%.
Wow. How old is he?
He is around 48, young chap. So, and immediately we took him for the intervention risk factors. He's totally better now, different deficits. So, the importance of knowing the stroke symptoms and taking action is...
Got it. So, I train in Japan for this fellowship in functional neurosurgery.
Wow.
And my professor always says, Japanese professor, a fool with a tool is still a fool. So today you have MRIs available everywhere. You have everything available everywhere. Your stroke-ready hospitals are available close by. We have doctors like us who are ready to treat them, but they don't show up on time.
Yeah.
And then they want everything to be done. I really can't understand. And that's why there's a difference between being literate and being educated.
True.
Having a degree is literacy.
Yes.
Being street smart is education. So that, you can make, otherwise, see this catastrophe, if it's happened to some young person, then for life you are stuck.
Yes.
I always tell my patients, see, even with half kidney working, you can survive. With half heart working, with 100% brain working, it's difficult to survive in this world. Forget about Alva.
True.
It is
You're not
so
properly
sad.
educated, don't have proper information.
Yeah. And the information is available, but people don't have access to it. I'm hoping that this podcast and talking to experts like you will give a little more, benefit to them to do that. Yes. So we were talking about TIA and early symptoms of stroke. So they come in there and then see again, now you have said TIA. They'll go to their family doctor. The closest doctor or somebody, they will go there. And some of them don't know, they'll write CT scan brain.
Yes.
Some of them just say MRI brain. Now, those scans turn out to be normal many times.
True.
Now, on one side, you're saying you should get imaging done. On the other side, you're saying the imaging can be normal, but it can still stroke. Why? What's going on? What's all this chaos about? Can you tell us, is it as simple or there's something more going on?
No, there's lots into it. That's how we need to know or we need to be educated about the stroke. Yes, when a person comes with a symptom, it can be a TIA. TIA by definition, the deficits can last for less than 24 hours. So the patient has come to you after the symptom has, you may not be symptomatic when he came to you. He had a weakness of right hand or right leg at home. By the time he came to your clinic, it will be normal. You do a scan, it's normal. It will be normal. But
it will be normal.
It will be normal in TIA, in transient ischemic attacks.
CT?
Both CT and MRI. The importance is of doing a stroke protocol scans. So what is a stroke protocol scan? First, we look into the brain. the structure of the brain. Is there any damage done already? Is there ischemia? There is an infarction there, clot. But very important to assess vessels. As I told you, stroke is caused by blockage in the vessel.
Correct.
As long as you don't see the vessel, the culprit vessel, your workup is not complete. So stroke protocol involves a routine sequence of MRI along with the neck and the brain angio. Angio in the sense, it's the imaging of the blood vessels.
Blood vessels.
So it's not only important to see the blood vessels of the brain, it's also important to see vessels arising from the heart which go to the brain.
Got it.
So as I told, it's a big pipe, then it goes branches out. We need to see all the pipes.
End to end.
End to end. And at the same time, should also assess for the risk factors. Whether he has any uncontrolled blood sugars, cholesterol, any other heart disease, other risk factors for the stroke. Then only you
put all the pieces
for the TI
together. Got it.
So MRI can be normal, don't get me, but if you have a symptoms, please see a neurologist for the further evaluation.
Got it. So before I go next to this, did you always want to be a doctor, or what's your story about? Why did you land up here? What's your story? Everybody has a story about being a doctor. As children, we used to get the doctor set and we used to put that in. What's your story?
I think mine is a very simple story in the sense, when I was a kid, whenever I used to go to functions, what my mother used to introduce to my relatives, friends. My son Anil, he will be a doctor.
Really?
Yeah, that's how it is. But you know what? It was no force. I liked it. I started liking it.
But what made her say that?
Basically, see, we were from a rural place, and to see a doctor.
Which place? Which place are you from?
Basically, I am from a Kolar district.
Okay.
And it's a very small place called Bala. I think just some 100 or 200 houses that time. Very few. There's no doctor. And for doctor, we used to travel. We used to walk 1 or 2 miles to catch a bus and then go.
Amazing.
And I always was amazed the way doctor diagnosed sitting there. And that time there was not much investigations available that time in the rural place. Only fewer. But he was doing a fantastic job. And I was...
The village doctor or the local doctor?
I was fascinated. And now that's how. And I think my mother's emphasizing again and again probably.
Very interesting.
I think then I did my medicine.
Correct. You have done internal medicine also.
Yeah,
I remember that.
Doing my medicine, I was very clear. In 3rd year, I wanted a guy to diagnose rather than the guy who wanted to operate. So I didn't want to cut anything. I didn't want to cut into tissues and see.
Got it.
I always, my brother is a software engineer. He always tells what doctor means you have to do operation. If you're not doing operation, you are not a doctor.
Yeah,
I said no.
That's what he says?
I said, so I always give an example. Like who plays a bigger role? When you're building a house, okay, the person who plans the building or the one the mason who builds it?
I mean, first
I know. So I think equally important is who plans it.
I agree.
Who tells where to put what.
I agree.
So I said that's what we do as a physicians. We diagnose and go. Okay, I think
very well said. In fact, I have one dialogue since you said who plans and all of those things. I always have this joke I tell my people. I said, imagine there was a doctor in whose house a tap was leaking.
Okay.
And doctor tried something to stop it. It didn't stop. He called a plumber. The plumber came and tightened something 2 minutes. The leak stopped. Doctor said, how much? He said, 500 rupees. He said, what? 500 rupees to tighten one nut?
Yeah.
He said, no, sir, 50 rupees to tighten the nut. 450 rupees to know which nut to tighten.
Right.
And that's where I think you physicians play a very big role. I completely agree with you. I have no qualms to say, because especially in neurology, so many times there's so much a difference between clinical and radiology. And that's when the clinical suspicion becomes so important for you guys to chase it. I think neurology is still struggling with the right set of tests many times. You want to comment a little bit? I know it's out of this one, but just to say how difficult it is for you as a neurologist sometimes to piece the puzzle together.
Yeah, before that I'll tell you why I chose neurology.
Correct.
As a physician, I practiced, mine was not a continuous thing. I took a break of 2 years after my MBBS.
Okay.
My mother fell ill when I was in internship. I had to take care.
Okay.
2 years. Then I was clear that I will take medicine. So I took medicine.
That's internal medicine.
Internal medicine, and there are a lot of subspecialties there: cardiology, nephrology, neurology, rheumatology, etc. As a physician, when I was practicing, it's about my personal thing. I always felt easy treating a patient with fever, cough. The time the patient comes, tells, I have a memory loss for 5 days and my hand is not moving. I used to get a bit jittery. I was not very confident dealing with the neurology patients.
Got it.
As a physician, I was talking about. And when
that is 5 years, 5.5 years, MBBS, 3 years of
internal medicine, I was still not very confident treating a neurology patient. It required more. And neurology is a vast
I
thing.
agree.
It's
I
not only a
agree.
brain thing. It's a brain, it's connections,
Spinal
numerous
cord,
connections,
the
spinal cord,
nerves. Yeah.
nerve, muscle, neuromuscular
I
junction,
forgot that. Yeah, that's where we stop. Yeah.
neurotransmitters in the brain causing so many
Oh
issues.
wow.
So it's a vast
Vast
thing.
subject.
So
I
I
agree.
think that actually interesting. And
Trigger.
second thing, if you see at the time, not many neurologists,
Correct.
not, there were, but very few compared to our population. So I thought this is a field I have to be there. Even after I do neurology, I still face a lot of changes. And I think it's not, the brain is one fascinating organ, you see. Now, one of my teacher used to tell me, you can change any organ in your body. You can still be Dr. Sharan Srinivasan. Okay, I can put a heart in you. You can be Dr. Sharan
Correct.
Srinivasan.
Correct.
You can change your kidneys. You can change your liver. You can put a artificial limb. You can still be. What if I put my brain into your you'll become Dr. Anil Ramakrishna.
Correct.
You'll not be Dr.
But in
Sharan.
Dr. Sharan's
That is the unique thing
body.
about that is the unique thing about the brain.
Very
So
I
you
agree
cannot,
with
you cannot. So maybe that's what the question, the other friend asked is, every transplant is, possible now. Is brain transplant possible? I said, yes, but this is the problem. If I put my brain into your brain, you become
Even if
that
you can, yeah,
that's a unique thing.
identity, you'll become a schizophrenic, I think, at the end of the
So
day.
it's an interesting organ and multiple functions from the millions of neurons what we have. It's difficult. I think it's a learning process.
I agree.
You've been in this world for so many years and you've done this rebooting.
Yeah.
You'll know better.
I agree.
It's not a simple.
But I'm telling you, every day the patients teach us so much.
True.
That's why we're always the student of the subject till we die. That's what is very, very fascinating
Definitely,
about
sir,
this.
definitely.
That's why your mother was telling you all. I should, you should check out. It's amazing, how they make up something and then they
Yes.
tune our minds to do that. I think many of them would have some things like this in their life that goes on to make it happen. Coming back to MRI, the diagnosis of a stroke. So you were telling our audience, global audience, that in the early stages of an ischemic stroke, this CT can be normal. Okay, not bad. Okay, now I do an MRI. So routinely, if you see everybody promotes MRI brain plane.
Yeah.
That's the normal request written on a request paper.
True.
And you're saying that can also be normal. Now, why am I asking you a pointed question now? Is we are going to the next step of treatment of early stroke in the so-called window period.
Yes.
So before I go to what the scan shows, can we tell our audience what is a window period stroke?
I think nowadays there is a lot of scientific innovations and we have a lot of gadgets, a lot of instruments, a lot of machines to diagnose things. But I think, what are the first thing which matters? I know the most important thing is a clinical diagnosis.
Absolutely.
See, until you suspect something, you'll not. You suspect properly, you direct your investigations accordingly.
Exactly.
So you don't suspect a stroke, you don't order a proper investigation.
Correct.
So it's not that, it's a set of investigations, go do and come, whatever
I've seen somebody getting vitamin B12 done sometimes for this numbness in the hand rather than...
So clinical suspicion is the most important thing to guide us. Yes.
Got it.
So in early stroke, CT scan can be normal up to 6 hours of stroke. Okay. And MRI can also be normal in 20% of actual strokes. 80% can be positive. 20% of MRI negative strokes are well known.
That is MRI brain plane, the usual sequences that...
That's why the stroke protocol matters, where you get both the...
What is different from a routine MRI brain plane and a stroke protocol?
So when you write just MRI brain scan, so the patient will go to the center or the radiology department, the technician sees it. So he has a protocol. There are so many sequences. He just does it and send it back. So now I don't know which vessel is blocked there, whether he'll have a stroke, whether, as I told you previously, that doctor had 95% block. This MRI brain was normal. It was only a stenosis, which that constriction in the vessel, which helped us to treat him. The stroke protocol involves a proper sequencing plus the blood vessel imaging, both neck and the brain. Now, you asked about window period. That means I have a window to treat the patient.
Correct.
So what happens when there is a blockage in the vessel? So obviously, it's like when you... Just to make the normal audience understand, there's a plant in your garden, okay? You don't put water for some time or a day or two. What happens to the plant? The plant dies. Yes.
May not die.
Initially, yes. And you give the water immediately after a few hours or something. Yeah, it recovers.
Correct.
What happens? You give water after 4 or 5 days. It won't, because the plant is totally gone. So that's the window what we have, that 1 day window. But in brain, it's not. It's in minutes. The brain tissues cannot survive without blood and oxygen for more than few minutes and sometimes hours. So after all the research has come to know that if you can open that blocked vessel, if you can open the tap and allow the blood to go back, we can salvage the brain tissue up to 4 to 4.5 hours.
Okay. 4 to 4.5 hours from the
up
point
to,
of
up to
stroke.
5 hours. Okay. So if the patient develops can go to a stroke ready hospital. What is a stroke? I think you already spoken about it.
But which I think no harm in telling about what is actually a stroke ready hospital. Does every hospital which has 24/7 emergency is stroke ready?
No.
So can you clearly give us points? Yeah.
See, at the same time the question comes, Doctor, I stay in a place, coming to your center takes me hours together.
Correct.
Am I not wasting the time? Can I go to center?
Absolutely.
You can definitely, but make sure whichever center you go has at least a scan.
CT scan.
If not MRI, CT scan is more than enough to diagnose.
Got it.
Okay, and the physician or if there's a neurologist, the best, and the physician should clinically diagnose it. So at least go to a center where there's a basic CT scan available.
And somebody should read the image immediately.
Yes.
Because there's no point coming tomorrow morning to collect the report. That's what most places do. Nale bunny report thoroughly, they'll say, which is
then again the question comes. One of my friends asked, when you know it's a clinical stroke, why do you need a scan? Because there are two types of stroke. And the treatment varies a lot.
Correct.
Okay. So first we need to know is it ischemic stroke or hemorrhagic stroke. The one scan is a must. Now coming back to the window period. Now I know it that if I open a vessel within few hours, I can salvage a tissue. So once the vessel is blocked, there are few neurons already died and other neurons are in the process of dying. If I can open the vessel within that period, that tissue can be salvaged and the deficits. So each centimeter, millimeter of brain has some function.
I agree.
Okay. You save 1 centimeter of a brain tissue, the lot of deficits.
Very true.
So the early they come to you in that window period, we can. So what we use about revascularization.
Revascularization.
The vascular means the blood vessel which is blocked. We are revascularizing. The blocked vessel we are opening. We are reopening the vessel.
Reopening the vessel. So we'll stay with this conversation of revascularization. So now you are saying that here a patient has to pick up the symptoms early, come early to a neurologist or some doctor who can clinically suspect he is a stroke and then make sure he gets the right investigation done. Yes. And that investigation can start with a CT scan to make sure there is no hemorrhage. And if the CT scan is normal, there is a point to celebrate that he is still in the window period. And the celebration should not be so much that you send him home.
Yes.
You have to chase it further. Then you're saying do an MRI. And the MRI has to be a particular sequence of MRI because a routine MRI can still miss it in the window period.
Yeah, if you can just intervene in this, we can do something called CT angio. Okay. If MRI you don't have to go running behind the MRI.
Got it.
We can do a CT angio. Angio is the blood vessel scan.
Got it.
So that will tell you which vessel is blocked.
Perfect.
Because why I'm telling in that window period, there are so many treatments available to open the blocked vessel. Okay.
I'm going to come to that. So So before you go to that, that's why I'm heading in that direction. So now first is you have to make sure, because if there's a hemorrhage, then it has a different consequence, a different plan of action. We're not talking hemorrhage stroke. We'll have to talk about differently because so much on ischemic stroke to talk about. Now in this MRI stroke protocol, we have a particular sequence called the flare sequence or the DWI sequence, where we see that if that is positive, rest of the MRI is normal, it's not a TIA, and that's when you think that something more has to be done. Then you have confirmed with an MR angio whether it's a major vessel block or a small vessel block. Now you tell us, today I think, I'm quite sure you also agree with me, more of our patients know about this clot busting drug that's, one injection kottharalla doctor and they come to us. At least that much has come.
Yes.
So, we are so happy when people hear that question. Unfortunately, some of them come in later than 6 hours, but at least there's some knowledge going on. What is this ANO1 injection that they talk about? Can you educate us what is this and how is it connected to a window period stroke and the special MRI that you do?
Yeah. So, the stroke is because of blocked vessel.
Correct.
It's simple. You have to open the blocked vessel.
Correct.
So how do you open it? You don't have to do surgery always. So there are medicines where you can just give glucose infusion. Like you take an IV infusion, you can just give
like
a injection. Yeah. And still there is an injection where you can just push. You don't have to give a drip also. Okay. Just push it.
Okay.
And that opens the vessel.
So this block is because of a clot inside the blood vessel.
Yes.
Got it.
Yes. The clot, the lumen is blocked. There is no blood flow. All we have to do is open it. So there are variety ways of opening it. So one is the easiest thing is to give the
injection.
IV thrombolysis.
Like you give it here only.
Yes, as an infusion.
Got it.
And there are two types of injection. One we give through an infusion over 1 hour. A second there's a bolus. Bolus means just push it into a vein and it blocks.
Got it.
So why is important? So some ask, why is it you give injection only in that 4 or 5 hours? Why don't you give later? So I always explain them in the layman terms like, when you come early, the clot will be like butter. It
Mm.
melts when we give the injection. When you come late, it becomes like a cement. It doesn't break.
Mm.
So, and whatever we try to do, the vessel itself can rupture later because it's thick.
Correct, correct.
So if you come in the window period, it's like a butter and it melts like anything with the injection. And the blood flow is restored, the tissue is, as I told you, the two IV thrombolysis, what you're talking about. One, the commonly used all these years is altiplase or a tissue plasma activator. It's not a big rocket science there, but you need to know how to and when to give it. Within 4.5 hours, it comes as a powdered vial.
Mm.
You just should put 10 ml of normal saline into it, shake it properly. Okay, I'm just simplifying things for the audience.
No, absolutely.
So what the doctor do, or if any general practitioners are watching this, to save time, to refer, all you do is powdered this thing, put 10 ml saline in this, mix it, 1 ml to be given bolus, 9 ml put in 100 ml NS, and NS is normal saline.
Normal saline.
You give over 1 hour infusion. Then the thinking started, you are wasting that 1 hour. Is there an injection which can save that 1 hour? So with this, I think a new drug has come. Now it's been commonly used called tenecteplase. We can just give a bolus dose.
Completely.
Yeah.
That's right. So
This opens up the vessel.
Got
Now,
it.
all the strokes can be treated like that. Majority. And it depends on which vessel. As I told you, it's a big pipe and a small branched pipes. Okay. The study shows that the injection works better for the small branched
smaller pipes, not the big
If there's a
one.
major vessel involved, we need to take it. Or like we do in the heart, the angioplasty, we do the angio here and take it out.
Yeah. So what he's trying to tell you, viewers, is that that's where that other part of the MRI stroke protocol of the angiogram comes into place to know whether it's a big pipe block or a small pipe block. And that information will decide whether you have to give the injection here
Yes.
or to go for the next
Absolutely.
level of treatment. So far we are good. So, but what I want to tell our global viewers is, you said the injection is simple, you dilute, but this injection is not available everywhere.
True.
That is why it's available
True.
in only a stroke-ready
Ready
hospital.
hospital.
Your doctor in the
Very
clinic
valid
cannot
point.
have it. Routine hospitals will not have it. Many of them would not have heard about it. That is the important reason why the stroke can happen 24/7 by 365. So it happens at the wrong time, you're in the wrong location, you
True.
have to find quickly what is going on. That is the other thing is important is we know that recently even Mithun Chakravarti Award.
Yeah.
You
I was reading in the
disco,
social media that
I
he
am a
had
disco
stroke. Oh.
dancer. We used to love
Okay.
that song. He had a stroke. That means stroke, like COVID, is very democratic.
Yeah.
It is not only rural, not only poor people.
Anyone can have stroke.
Anywhere in the
anyone
world,
can have stroke.
yes. That means literally, like COVID, all of us are theoretically at risk. So that is one of the bottom line messages. Some risk may be more, some risk may be less,
Yes.
and then God is there.
But not to worry. Obviously, you have to simplify to yourself or individuals to yourself
yes.
whether you are at a risk.
Yes, and
go
take
test.
precautions. Take precautions for
Take
sure.
precautions. And because you took a celebrity name, I'm so happy that Gavaskar has been roped in as an ambassador. I'm so happy. As a neurologist, I always felt the general population of the people knew if this is chest pain, they'll go to a cardiologist. If they have a breathlessness, they'll go. But if they have a hand numbness or weakness, as you said, they don't know it's maybe a symptom of a stroke.
Absolutely.
I think the stroke awareness is an important thing, and roping in a celebrity like this helps.
And Dhoni, who also spoke about it.
It helps us.
I agree.
Lot better.
So not only they don't know it's a symptom of stroke, they don't even know window period. So both are equally important at the end of the day.
True.
So let us now delve for some time. You said, in the beginning of our talk that each area of the brain is different based on which area of the brain gets affected. Some people have vision, some people are here. So from the order of common to less common, because most people's understanding of lakwa or stroke is one side weakness,
Paralysis, one side
paralysis,
weakness.
one speech is not. Beyond that, they don't even think anything is going on because they can't see it. It's a software problem of the brain. So can you lucidly tell our viewers step by step from the commonest symptom to the less common symptoms, what does that word mean medically and what does it mean for a layperson so that they are aware of each symptom, what happens?
Yeah. So brain, as I told you, is a huge structures like a garden. So we have a front brain or a forebrain. We have a back brain or a posterior brain.
Correct.
And the deeper structures and the brainstem, which connect the brain to this thing. The
Got
symptoms depend upon which structure is involved.
Got it.
For example, there's a lobe in the front called as frontal lobe.
Correct.
Okay, and behind there's a temporal lobe. If these structures is involved, because the commonest vessel, the culprit vessel in all the strokes, what we call a middle cerebral artery and its branches.
MCA.
MCA, middle cerebral artery. So if depending upon the area involved, they can present. If the frontal lobe or temporal lobe is involved, they can just come with the language problems, okay, speech problems, what we call aphasia. Okay, so aphasia, again, an interesting thing. They can be broadly divided into motor and sensory aphasia. One where they understand everything, they talk to you, they understand everything, but the word output is less. If you ask, where are you from, they say, they understand the questions. They may try to say, but the word output is less. I'm from Bang. That's what called motor aphasia. This because the involvement of a lobe called as frontal lobe. Whereas the other thing, just ask, where are you from? He says, I'm from Bangalore, and then it goes on and on and on and on. It doesn't stop with no sense to what you asked. What we call in layman so the verbal diarrhea or a sensory aphasia. So the lobe involved here is frontal or temporal lobe. Okay, and if the adjacent area it's more involved, they can develop one. Here it's always the opposite side. If the right brain is involved, you have a left side weakness. If the left brain is involved, you have a right side weakness.
Got it.
Okay. The common thing what everyone knows paralysis, as I said, it's called as plegia or hemiplegia. Plegia means paralysis.
Complete, 100%.
Plegia means paralysis. Paralysis means weakness. There are many terms like that. There is most commonly what everyone knows, hemiplegia. Hemi, English means half. If half is involved, it's hemiplegia. If one hand or leg is called monoplegia. If both legs are involved, it's called paraplegia. If all the both hands and legs, it's called quadriplegia. So again, it depends. For example, if as I told some brainstem which connects the main brain to spinal cord, if those areas involved, they can have a quadriplegia. Like they can have weakness of all
four limbs.
Or if the front brain, one side is affected, the other side will be weak. And sometimes there may not be weakness. There's something called as posterior brain, or what we call a cerebellum and disconnection. If it's involved, there won't be weakness at all. All they have is an imbalance. So when you test for like what we just lift your hands, hold my hand, everything will be normal. But when you make them work this way. So the imbalance can be because only imbalance, no power loss in cerebellar involvement. If the deeper structures are involved, they can present with cognition issues, memory issues.
Correct.
Those things.
Word finding difficulties.
Forgetfulness. Yes.
So it's so subtle sometimes, it's quite frightening.
Sometimes they just come with what we call an apraxia. In the sense.
What's an apraxia?
Yeah, it's like, not able to do a purposed motor work on a command. For example, you asked him to comb a hair, you would hold it.
Look at the comb like this.
And then comb. Or you give a shirt to wear him, you may wear it the other way around.
Upside down. So this can be because of involvement of a lobe called parietal lobe and sometimes frontal lobe. So depending upon stroke doesn't mean there's only weakness of hand and legs. That's the first another message. So viewers, you need to understand stroke doesn't mean just one side paralysis, one speech problem. So what Dr. Anil said is very clear. One side of the brain controls the opposite side of the body. That means the right brain controls left side and the vice versa. The other thing I want to add to what he said, he spoke about the speech area. One is the understanding speech area is comprehension. First of all, you have to see when we are speaking right now, you have to first understand what I'm saying. Once you understand, you interpret what I said and then you give a appropriate output. So understanding area gets affected. You don't understand what I say. You keep talking what we want. That's called verbal diarrhea. And if you understand and not able to give a verbal output, that's called Broca's aphasia or motor aphasia. One more thing we didn't talk about, Anil, is a wake-up stroke. So what is this wake-up stroke? Can you help to educate our audience about that? It's the person having stroke symptom when he gets up in the morning, which he didn't have while going to the sleep. He normally went to the sleep, gets up in the morning, and he sees that he is not able to move one of his hand or leg or any of the stroke symptoms that we discussed. Maybe blurring of vision, maybe slurring of speech, not able to hear, imbalance while walking, weakness of hand and legs. Or the family may see he is unconscious or something like that. Yes, they may find that, he went to bed normal in the morning, he is not responding. This is wake-up stroke. Why is it important? What are the challenges in this? I was going to ask you that. Because we spoke at length about, window period, opening the vessel, the time frame and other things. Correct. So this wake-up stroke, how do you know? It happened at 5 a.m., 9 p.m., 12 p.m., we don't know. That's right. So how to do it? So obviously the imaging is the first thing. In there are few parameters which will guide us. The common one what we use is called as diffusion flare mismatch. When you do an MRI, there are so many sequences. See, I think most of us will get an MRI sometimes in our life. There won't be one picture, there will be multiple films and multiple things.
because you do different sequences to look for different things. So there are two sequences in stroke protocol where we see diffusion weighted, which picks up the acute stroke, and there's something called as flare, which we see it. The stroke, if it's occurred few hours back, you see the changes there. For example, if you do a MRI scan within 20 minutes an hour, the changes may be seen in diffusion weighted images. It won't be seen flare. What we call a diffusion flare mismatch. So how does it help me? So I have a wake-up stroke patient. I do a scan, and if there is a diffusion flare mismatch, tells me there is huge tissue to be salvageable. I'll take immediately for.
You can still.
I'll open the
give in
vessel,
benefit.
IV thrombolysis or something. For example, when I do a scan of the wake-up stroke and it shows in both the sequences established, I may not lyse it because the risk of bleed also is there. That's the challenge when we have a wake-up stroke.
Got it. So wake-up stroke is another concept people should understand. It doesn't mean that you woke up with a stroke is a bad prognosis. You still show up as early as possible, and you never know. You may be one of those lucky people with a diffusion flare mismatch, and we can do that. Good. I think that's an important point.
In between, you mentioning about stroke mimics. Just to clarify things, that we try to rule out majority of stroke mimics before we embolize. The most common stroke mimic is hypoglycemia, because in India there are a lot of diabetics. There are so many diabetic medications. Some are on insulin, and they come as a stroke. And first thing is we do a random blood sugar, GRBS. It detects within few seconds.
Got it.
So then we treat normal. So we try to rule out most of the stroke mimics, and then go whatever possible. Okay, the common one is that sugar thing, which. So even at your home, if someone is not responding, someone is confused, slurring, if you have a glucometer, do a sugar. It hardly takes few seconds. If it's low, rush him immediately, or you can give some sugars there also. And then.
Got it. Perfect. I think that's a good point that you have said. Now, I have another question for you. All of us say handed. Are you right-handed? Are you left-handed? For the general population, right hand, left hand is okay. Lefty power and things like that. And we have cricketers like Saurav Ganguly and all left side guys that have this own fancy stuff. Adam Gilchrist and all, Yuvraj Singh. But what has handedness got to do with the brain and a stroke? And is it important? Is it important?
Very important in the sense that tells you, like, we have two hemispheres, like right
two
and
sides
left,
of the brain,
which tells which is your dominant hemisphere, which is that hemisphere which is doing majority of the work, or which guides you to talk, understand other things. So most of the right-handers will have a left hemisphere dominant. It's very important when it comes to stroke and stroke prognosis.
Correct.
So
prognosis means outcome of a stroke or recovery of a stroke.
Outcome of a stroke. So generally we ask handedness to know which hemisphere is dominant. As I told you, majority of the right-handers will have left hemisphere dominance. Correct. I'll just give an example. Like a patient comes to my hospital, and I get a call from one of my junior colleagues telling that a patient is there with a stroke. My first question is, a dominant or non-dominant hemisphere? Because I know if it's a dominant hemisphere, the patient will have much more deficits. And the outcome will not be as good as a non-dominant hemisphere. If the vessel carrying the blood, the major vessel to the dominant hemisphere is completely blood, the outcome is not good compared to those things. The dominance helps us.
Got it.
To prognosticate things.
Got it. So you're saying that for most of us being right-handed, for us, the left brain is dominant because also the left brain controls speech. And the only, like I tell all my patients and my colleagues, the only thing that separates or what differentiates human beings from animals is communication.
True.
And if you can't communicate, you're no different from an animal. You're just going around doing your work, going to bathroom, coming back. Those are all vegetative works. But for you to communicate and communicate effectively is language. And that's unique to human beings, though animals also have their own set of languages. So if language is left brain dominant, as what you're saying, so what happens to the same area on the opposite side? So if the opposite side gets affected, do they have, what language problem do they have? Or is it sleeping, or is it a dead area, or what do you think?
This is just to tell that the dominant area generally guides the language.
Correct.
And other things. The other hemisphere is important too. There will be a lot of connections between the two hemispheres, which guide us the proper coordinated movements of the hands, legs, and everything. So if the non-dominant hemisphere is involved, you can have weakness on one side, as we discussed.
Yes.
They can have this apraxias. They can have confusion in doing the movements. Their cognition may be affected. So it now lobes is just to describe it. Nowadays, it's all about networks.
Correct.
The brain is full of networks.
Thanks for bringing that word
Yeah,
up, networks.
I know it's your favorite thing. It's full of networks, and each part, as I told you, each part of the brain is important. It is connected with another part.
Absolutely.
So every part has some function, and if it's damaged, you'll have a deficit or a symptom.
So you remember, guys, there's something called LAN in every office. LAN is local area network. Without the local area network, this computer will not talk to that
True.
computer. Same thing you're talking the human brain.
Yes.
In fact, whenever I go for my talk, especially when I'm talking to non-doctors, I tell everybody, hi, I'm Dr. Sharan Srinivasan. I'm a functional neurosurgeon. I come from the Silicon Valley of India, which is Bengaluru. But I come from the original IT industry, which is the central nervous system. Everybody else is a poor copy of that. The next thing I have added to this is the network you phrase. There's ANN called artificial neural networks. This is a big subject. I don't know whether you're aware of that in this engineering class. And they have learned artificial neural networks from the natural neural networks, and then trying to extrapolate that. Now we are now trying to understand the natural neural networks to see how we can impact patients whose those networks are malfunctioning, to see how we can help. So that's what he's saying. You understand, each one is different. So now you see I'm moving both my hands. And when you open the bottle, you hold one and do that. That means both your hands don't do the same mirror activities. One does one work, the other does another work. That's the job of the networks to make sure that which hand should do which work. If you're holding with this, this will do this. If you're holding with this, this will do this. That is how the networks work very, very clearly. Just to add to what you said about the speech, you have the emotion component of speech, that comes there. And the prosodias, as what we call prosody, or the emotional. Others will be like a like Indiran, like our Indiran. Or the,
you don't have any emotions on your face.
The Indiran 2.0 was, how do I put the emotion inside that to get married to Aishwarya Rai? That's how to express love, and that's how the emotion came in. So the prosody is how to understand emotion. If I'm angry with you, how do you know he's actually angry or upset with me? And when you express anger or upset or love or happiness, that's called this part of it. So can you see all that? You want to add something to that?
When you're talking about the networks can damage because of this vascular blockage, the blood vessel blockage, stroke, and other. But also remember that networks can grow back. Like, where the roots sprout, there's something called as neuroplasticity where the term of rehabilitation comes in. Okay, so I think that we will discuss.
Yes, but
network damage. Yes, we need to prevent the damage first. We need to know when damage occurs, what occurs. Those are the symptoms. When it occurs, where to go. And there's not the end of story. We need to make sure that networks grows back again.
So that means you're giving hope to our patients. That
definitely,
if you have, for your bad luck, if you have had a stroke and you have had a network damage, it's not the end of the road. There are enough patients, I'm quite sure you have and I have, who have not just recovered from a stroke but gone back to their previous job and things like that. Everybody is not as lucky as we know, but that's why we say God is great and those things. And today actually I want to add, since I'm mentioning about God, I want to add something here. So I told you the story of what yesterday one patient's father who had a stroke in the beginning of this chat. So one of our Chotu speech therapists, she's a young speech therapist with us called Sneha. She's a speech therapist. So for some reason, she tagged along with a senior person to go, to a hospital last evening to see some other patient. They thought they had a problem. When they were in the hospital, they got a call about this. So she saw that whole drama of patient being shifted to the emergency, checking this, shifting to MRI, the frantic calls going on, check this, do this, do that. And at every point, a decision was made, next decision was made, and how the whole thing got, and he's better. She called me this morning and said, "Sir, can I share something with you?" I said, "Sir, today I understood when you keep saying there's a power beyond us who's there, to look at us.
Definitely.
I don't know why I went there. I don't know why we went to that room and saw this, caught it so early, because he was in the window period, because of which he's much better today. Now I understand what you say about God or destiny or whatever it is." And for her, she says, "My life has changed." Just that one experience she's had.
I think when we both are working in a Jain hospital before, I think I discussed with you. We had two young patients. Okay, one what we just spoke, dominant and non-dominant hemisphere. One had a dominant hemisphere blockage, stroke, and other had a non-dominant. So as a book says, we were all thought, the dominant will not do better, the non-dominant. But the family were very supportive. And what happened? The dominant hemisphere did better than the non-dominant. There are other things Yes.
Beyond us, that is also very important.
Yes.
Positive energy, positive result, negative energy, negative result. There's no question about that fact. So now we have finished window period stroke. We spoke about TIA. We spoke about the type of investigations to be done. We just looked at big vessel, small vessel, the different areas of the brain that's affected. Each of the area has its own story to tell. Based on the story, we know what is affected, what are the problems that he also used the word deficit. Problem, deficit is about the same, just the different words that we doctors use to measure that. And if there's a clot in the smaller vessel, you give the clot busting medicine here. If not, you have to do what? So I'm asking you the next question. If it is a major pipe block, then what happens to these people? What should be done?
I think I'll just summarize in a minute so that
yes.
from what
sure,
we spoke.
sure.
Yes, first, to be aware of the stroke symptoms. Yes, you know it's a stroke symptom. Please rush immediately. Don't waste any time.
Correct.
To a hospital where there's facility to see stroke. At least a CT scan available. Correct. And if neurologist or neurosurgeon are there, great. So we identify stroke, small vessel, we give a lysis. If it's a big vessel, now obviously the lysis won't work better. What is it, big vessel? As to tell to the commoner audience, like we have a heart as a pump, from there we have a major vessel, what we call a carotids on both the sides. The one which carries to the blood called internal carotid, which then branches out to give a middle cerebral artery, that MCA, and then ACA. And from the other, what we call the posterior circulation mainly consists of vertebral artery and which joins the basilar artery. This carotid artery, the middle cerebral artery, the basilar artery, these are what we consider as the initial part of the anterocerebral and the middle, we consider the larger arteries. Because it's a larger artery, it carries a large blood to the large portion of the brain, the deficit will be huge. It's better we revascular, we better give something else better than this. And the research shows that this vessel, if you remove the clot, it's better. Mechanically, that's how the term mechanical thrombectomy came. So we don't waste any time. Okay, so I personally don't do a thrombectomy. My colleague does it. So as soon as the patient comes to stroke, I lyse the patient what have been. Then we take to the cath lab. We see if we can remove the clot. Great. That's what called a mechanical thrombectomy. Generally reserved for the larger vessels. Got it.
So that also, there's one more in your toolkit that you can do. It's not that if I can't IV, that's the end of the road.
Yes.
We still have something else, and that results are equally dramatic.
Yeah.
I'm quite sure you also agree with me. We have seen patients who have been like this, and suddenly the hand lifts up the moment we get the thrombectomy done. So that is good. So next question commonly people ask is, within 1 week, doctor is not improving. What is this? So people want results like Maggie noodles today. In this world of
fast
instant
food season.
Fast food, instant gratification. Everybody wants instant results. So can you tell our audience that the recovery is not like Maggie noodles?
Yeah, here I need to emphasize two things. One, stroke is treatable, okay, and majority of the stroke patients improve. But there is one problem. It takes time.
Okay.
Now,
why is that a problem?
Yeah. Whenever a patient comes to me, I ask them, okay, so you had a scratch there, okay, did you heal in few hours? No. What happens? It takes few days, it forms a scab and then leaves a small scar there. But brain, as I told you, each millimeter or centimeter matters, so it leaves some deficit.
Absolutely.
Here it's days, there it's few weeks. Patience and optimism is the important thing. Okay, you will improve for sure. Yeah, with a little bit of disability if it's a larger stroke, but recovery will definitely come. It takes time because the neural tissue takes its own time to recover.
Got it.
Very important. And they understand, and you don't not to give up. So it definitely improves, and most of the stroke, if it's a small stroke, they improve within few days to weeks, and larger strokes they improve. But very important is after stroke care. I think we'll discuss that in detail later. I think that is most important.
I agree. We'll go there. So what you're trying to say is that in that concept of time is brain, depending on how much of time is lost or how much of brain tissue is damaged, from very minimal or no deficit to some permanent deficit can happen. That's why the urgency is important. The right action in the right place is what you're driving home the point. And you have spoken about neuroplasticity, which means the circuits can get recovered.
Definitely.
If lot of the right things are done. Now, there's no one right thing or one formula that happens. That's why you leave it to experts like Dr. Anil, who when you go to him, in that particular situation of a set of symptoms, a set of things that's going on, you will be the right person to decide what is to be done. Now, Okay, we spoke about acute care.
I think we were talking about window period. There, I think we need to discuss about these terms called as umbra and penumbra.
Yes,
Very
thank you for
important.
bringing that up.
The
I
whole
missed
thing
that.
is depending upon this concept. What is this umbra? What is penumbra? And what is the importance of these things?
For me, before you take that, when I read this umbra penumbra in the context of stroke for the first time, what came to my mind is my school.
Eclipse.
Eclipse. That's right. So I think
Okay, because you took that, let's try to explain from there. When there is an eclipse, so you see one darker area in the thing. Okay, that is called as umbra. Okay, and surrounding that will be a light, not that brighter side, not that dark. That is the penumbra. In stroke, that umbra, the darker side, what we call ischemic core. Like there is a blockage in the vessel, there is some tissue at danger, there is no blood. Now it forms a ischemic core that it's going into a dead state or a necrotic state, what we call as umbra or the ischemic core. Surrounding that is the one which is high danger, because if you don't open it, even that tissue eventually will go.
So that becomes.
But if you can open the vessel within that, the whole penumbra can be salvaged.
Fantastic.
So penumbra is a target for all the revasculation we have talked about, whether it's IV, thrombectomy, everything.
Fantastic.
So it all depends. So the patient has a large penumbra, you can save a lot. And
so that helps you to prognosticate what is the possible outcomes or at what level it will function.
So how do you know how much is a penumbra
I was
here?
going to ask the next question.
Yes, that's so. Even we have an imaging technique for that. Okay, there's something called as perfusion scans.
Got it.
Where it tells us how much the blood is blocked and how much is at the risk. That's what we see in that perfusion scan. It's a colored scan, colored coded thing. It tells us, this area it's still not totally gone. We can still salvage it. So if you can open the vessel within that, we can, the lot of deficits can. There are so many examples. Patient just come with weakness of one side. We revascularize the patient with this and they go completely normal. And today you cannot decide.
You can't decide. So I think that's where we say about the perfusion mismatch here. That's what you're saying.
Yes.
The larger the penumbra is, the larger the mismatch we call it, and better the outcomes versus that.
If you can intervene at that time.
Exactly.
If you can revascularize.
So as much as technology is coming and supporting people like you and me to give more information, qualitative information, so that we can make decisions which will eventually impact not the now but also the future. But also, that's only so much useful if the patient doesn't come to us on time.
Yes.
I heard globally the statistics of people coming in the window period is 4% or something like
that. Very less. Huh? Very less.
Why is that?
And in our country, still less.
Still less, huh?
Yes, still less. So, things are better now. We hardly used to get patients in a window period. Even now, majority of the patients come out of window period. They come. That's where this awareness is so important at Sheraton.
I agree with you.
I'm so happy when you said, so many celebrities are coming, So how does the awareness come? First, they should know
some
symptom.
of their heroes has to talk about something. Otherwise, only then they will. If they program, do this, they will promote it than anything else.
The program you're doing right now helps a lot.
Which is why we thought we should do it.
Yes, utmost important. Yeah. Until you are aware, you'll not seek help at all. The problem, as you said, you call it a brain attack. Yes, absolutely. Heart attack at least gives you pain. But let's go. The brain attack doesn't give you pain. We're talking about the ischemic stroke here. It may not be painful. And as I told you, it may be just a numbness or a weakness. And by the time they realize it's a stroke and come, that golden period or a window period, what we call, is lost.
It's gone.
So awareness is the most important thing. I think the media and the papers, television should do a lot of things. And I think what Sir is doing, I think is an amazing thing. This should reach the maximum people so they can be aware about the stroke and the burden can be reduced. See, when the stroke affects, it's not only the individual. Think about the family.
Just before you go into that. So what Anil is saying, Dr. Anil is saying very clearly is today in the world of the WhatsApp university, the number of forwards I get is amazing. But the useful forwards is very less. So we are requesting you people to forward such kind of videos and such kind of links so that the maximum number of people understand this. You don't have to come searching for Dr. Sharan or Dr. Anil. Go to the nearest stroke-ready hospital. There are hundreds of Dr. Sharans in the country. There are hundreds of Dr. Anils in the country. All of us are trained to do this. But what you have to do is to show up on time. And that is the key. Because the price to pay for the loss of time cannot even be quantified at the end of the day. And like you said, coming back, not only the patient is affected, the family is devastated. So can you give us some stories of what happens so that the people can understand it's not a small thing at all for
Yeah.
them to neglect?
I think we'll come from the corner thing. The taxi driver that is admitted now.
Mm-hmm.
Okay, he has the clot in the left brain and his right hand is not working now. So his job is gone. There's no job, there's no income, the family is dependent on him. So it's a devastating thing. That's the importance of the stroke, stroke prevention first. And if stroke occurs, to reach the hospital on time first. And third, the recovery part. Okay. See, each step is important. The awareness is important, treatment is important. At the same time, even the rehab is important. If you can give him the right hand back and if he goes to the driving, nothing like that.
Absolutely.
Okay, the person's life is affected. He will be depressed because of the stroke. There's no income to the family,
And many times the wife is uneducated.
Exactly.
She's sitting at home.
How many are
small
working in
children.
our country now? How many wives are working? You still have large families where there's still a
The
housewife.
woman, yes.
So even if both are working, who will take care of the patient?
And the children.
Children. And taking care again, it costs. It's a huge burden to the healthcare
I agree.
also.
Yes.
One is
nowadays,
treatment and also the rehabilitation. It's huge.
Huge. And nowadays with the nuclear families coming in and no social support, it has become a curse today too. In fact, I tell all my people around me, you can't afford to fall sick.
Yes.
Literally, we service our cars, we service this one, but we don't service the vehicle. Only Sankara Bandha Venkatramana Tara, only breakdown management we do. And that is the worst thing to do because prevention is the best, safest, and cheapest cure and not anything else. I want to talk about these blood thinners. What is the role of blood thinners in different areas? You spoke about TIA, you spoke about early stroke. What is the key that to do? And can these blood thinners even given outside a hospital situation? Can you educate our audience about that?
I think very important question, and because we spoke so much about reaching the hospital early and things.
Correct.
Okay. I think when it comes to the paralysis of the cardiac, they say you carry these 3 tablets. I think the video also went viral.
Correct.
Always keep these 2 tablets in your pocket as soon as your chest pain.
Correct.
It doesn't work in stroke.
Doesn't work in stroke?
Doesn't, because I'll tell you why. Because
I thought it would work.
It won't, because first of all, though the ischemic strokes are majority, there are few hemorrhagic strokes. No, what if, you have a stroke and you give this blood thinner tablets, he'll bleed more. So that will not work in stroke. You can't do that, one. And second thing is, if you already given the blood thinner, the thrombolysis which we talk may cause more bleeding issues. That is one. Okay, one, in TIA, it's a transient one, recovers. But definitely the body is at a risk to develop. It's in a way, the body is giving you the warning that you're going to have a stroke in the future. That's what we put it TIA as. So how do you prevent it? First, obviously, you have to look for the risk factors. Which vessel is blocked, which vessel is going to be blocked, that to be assessed. And these patients, we start them on antiplatelet list. That is like blood thinners. Blood thinners are 2 types, what we call. The one which act against the platelets, the one which acts inside on the coagulation path. They're 2 different. So depending on the patient's risk factors, we decide on one. So in TIA, definitely after we do all the workup, patient will be started on blood thinners. And majority, they have to take it for a long term until we find out the cause. Second, we give IV thrombolysis, like assistant, we did thrombectomy. That's it. The clot is formed. There's a tendency to form the clot again and again. To prevent that, we need to give blood thinners.
Got it.
So generally, most of the blood thinners are for many years and sometimes lifelong. Okay, so there are so many molecules available right now. Okay, commonly used ones are aspirin. The other one is clopidogrel. Okay, and they go for many years.
Got it. So I want to play the devil's advocate to say, so you heard Dr. Anil say that, you do mechanical thrombectomy, you do IV thrombolysis, we got great results, patients do well. But obviously it's not 100%. Nothing in life is 100% and nothing is only one directional.
Yes.
So can you just give them briefly, what are the risks involved if you agree for the clot busting medicine or a thrombectomy? Is it 100% risk free? Or is there something that you would tell your patients there's a small inherent risk for certain things?
As I said, there's nothing 100%.
Even going in the bus, crossing the road as though guarantee.
So the best treatment option available today in world the worldwide is thrombolysis.
Correct.
In simple, thrombo means clot, lysis means breaking it down. So it can be IV or putting a catheter. and
Clot
take it out.
buster.
That's the best treatment available. No confusions regarding that. No. But yes, it will come. So it may break the vessels somewhere else and they can have a bleed. Or the culprit vessel which is blocked, sometimes it can break and cause bleeding inside the brain, causing effect. The percentage though is very small.
less.
There are few people who are at high risk. For example, like the patient is already on a blood thinner. He had some cardiac event in the past. He had a heart attack in the past, or some other blockage, or in the leg, or what we call deep vein thrombosis. He's on a blood thinner. On top, we lyse him. There's a high risk of bleeding in that. Okay. Or if the patient is another medication which influence this clotting mechanism, they can also have. Generally, the risk is less,
very less.
but we individualize it. If the BP is very high and we lyse, sometimes they can lyse it. See, what my philosophy and what I always tell my patients about balance of life.
Correct.
What if I do? What if I don't do?
Very good. Very well said.
So just imagine
the pros and cons is what we call.
Yeah, just imagine this sequence. A patient comes to my emergency. He has got a dominant hemisphere stroke. Okay, it's a big one. The major vessel is blocked. Now I need to open the vessel.
Correct.
Okay, and there is risk involved.
Correct.
So I think majority, more than 90%, it will open. It may not break, but there is 5 to 10%. But for that 5 to 10% for the patient, it is 100%. So if the attender, the patient family asks me, is it safe? I can tell yes, it is safe to the majority, but there's a risk involved.
Correct.
What if I don't do it?
That's a good question.
The left brain is gone.
Yeah.
So he'll be
100%. That's a guarantee.
Yes. So the left brain is gone. Throughout his life, he'll not be able to talk. He'll not be able to express. He'll be bedbound. His right side will be weakened. What do we choose?
Well said.
It's like a balance in life. I think we should take a little bit of risk and then go ahead. And
I think you have touched a very important, yes, a sensitive topic, because everybody doesn't think the same way. So let me understand and articulate for our viewers. What you're saying is there's nothing in life without risk. That's the first thing. And you're also saying in such situations, the risk of not doing is much higher than the risk of doing.
Yes, definitely.
Because it's like, saying that I will only go to exam if I guarantee 90% marks, which is not going to happen. Or if I win the match, that's not going to happen. And that's what like Krishna told Arjuna in Mahabharata. He says you have to fight for dharma, you have to fight to win. But you may not win all the battles. Yeah. But please understand that if you do not fight at all, there's only one result at the end of the day. So that's a very important thing that you said. I want to add one more very interesting thing that I'm quite sure you're facing in practice. Any patient, the moment I write any medicine, sir, what is side effect?
Yes.
Have you explained? So I would say,
yes.
Then I said, listen, when you eat pani puri on the roadside, they don't ask side effects. Correct, no?
Yes.
When they eat some nonsense from nobody asks. All the processed food, nobody asks. Fast food, nobody asks. Some other local medicine, they don't know. Only our medicine. Why is that, Anil? What do you think is the problem? Why only when they come to... See, first of all, I say, because whatever you've done in your life, you have come to us with this side effect of not being well. Now, what is the problem? The same thing happened during COVID time. People would say, sir, now hospital COVID COVID is happening outside the hospital. Inside the hospital, all of us are negative.
And the statistics say that majority were got the COVID when
they
went to mall outside.
What is the damn psychology of these people? And why don't you help me break this? Because let people get some sanity in this whole process. So tell me your take on this.
Oh, same problem. I face it. So I think I give the same parallels. So most of them do understand. But as you said, that's what, coming back, so the people drink multiple carbonated drinks. I will not name any, but it's on which has only sugars. Okay, and there are so many ready to eat things which has some additives. I think recently, Bangalore banned a dish which was a favorite.
Even palm oil has had so many risk factors now. They're talking about we are importing by the billions of tons.
Yeah. The common list, paracetamol can have a side effect. It can cause gastritis. It doesn't mean that you don't take it for fever. So as you rightly said, sir, there is side effect with everything. But we have to use it judiciously.
Absolutely.
It's again, I think it's come to balance. Like you have a fever, you can manage without this thing. You can do a tepid sponging. You don't take paracetamol. Simple as it. But you're taking a paracetamol, you're accepting that there is 1 to 2% risk of a little bit of gastritis and other things. So that we need to. Same thing applies to stroke. Yes, most of the times it's a safe procedure, whether it's IV thrombolysis or other things. Please go for it if it's an ischemic stroke in a window period. The little bit of risk associated, yes, we admit there is a little bit of risk which we need to weigh and take it.
So I just want to add my 2 cents worth to the rebleeding that happened. We call it revascularization hemorrhage, as what we call. So when the blood vessel
Yes.
gets blocked from inside and the brain gets damaged, whatever it is, there's something called the BBB, not Bisibele Bath, blood-brain barrier. So that blood-brain barrier gets damaged partially. And when we restore the blood flow into this damaged brain, sometimes this bleeding happens inside. So, but that's a risk we take. It's not like he said, it's a small percentage of people, but we have to be aware of the fact that that is inherently possible.
Yes.
That's the first thing. Second thing is, Anil, people you are giving this antiplatelets or blood thinners long term.
Yes.
What are the precautions of what? Because everybody doesn't tolerate the medicine the same way. What would be the routine advice you will give people if they are on these blood thinners? You're giving them long term. What would you tell them?
First and foremost, please don't stop the tablet abruptly. Very important. The tablet is given for a certain purpose. Okay, and if you stop it, there may be reblockage again. The first thing I would like to tell that. Okay, and second, I think as a patient, as a family, they are worried about something else. You're giving a blood thinner. If they have a cut, they'll bleed to death.
Correct.
No, you won't. You won't. Yes, but you take certain precautions. Make sure that you don't get hurt, or if it's a cut, give a pressure immediately, and then go to the hospital. Most of things are safer medications, not to be one to take this on time, but there are few precautions in the sense like there is a bleed from your nose, or when you pass urine or motions, like if there is,
or while
bleeding
brushing the teeth.
breathe, there is then stop the medication and go to your doctor immediately.
Perfect. I can tell my mother's story. So when she went on blood thinners for something, so she had this easy bruisability as what fair.
Yes.
The moment you hold her hand, she would get a blood clot there. That's when it's a warning sign that maybe the dose is too much, or maybe she is not tolerating the dose.
Yeah,
then
maybe
you have to
to
sort
reduce
of
by 50%.
reduce the dose. So when you see things like this, even small brushing the teeth, the bleeding and all that, please go back to your doctor and see what's going on. Guys, I'm repeating again, this is not a treatment program. This is an awareness creating program. Anytime you have anything that's going on, please see an expert doctor.
Yes.
And he will be the right person to guide you in your situation. What is the right thing to be done?
Yeah.
I think that's the key that we want to communicate.
Continuing with that antiplatelet precautions,
Yes,
you said.
yes.
See, nowadays dental issues are common, and sometimes they slip in the bathroom. They have accidents or thing.
Correct.
They may end up having a surgery. What to
That's
do
right.
with that? Blood thinners you cannot operate. Yes, you need to stop it, but you need to go back to your treating doctor and ask. Okay, there are so many instances which I have seen. For a simple dental procedure, they stop the blood thinners and they come back with a stroke. Okay, because you're taking out the blood thinner, there's a theoretical risk of the blood vessel getting clotted again. Very common, and it's common in the sense I've seen in my practice. So make sure that you go back to a doctor. There is an alternative for it. He stops the medication, but he gives some other injections for a few days and then covers it up to reduce that clot forming risk.
Perfect.
Again.
Well said.
And
thank you for saying
very
that. I think it's very important because to solve one problem, you can't create another problem, which then it gets messy.
And sometimes what happens, they stop the medication for a procedure and they forget to restart it.
Yeah.
So please make sure that, I have quite a number of patients. When I see, yes, they said, oh no, I stopped that time and, forgot to take it. I thought that's it. No, please make sure that you restart your end.
And I just remembered this, so I'm just bringing it. It's like blood pressure. A lot of patients I've heard would say they would have stopped their BP medicine.
Yes.
I said, well, sir, doctor, I took it. My BP became normal, so I stopped it. I mean, can you imagine?
BP will be normal when you take a medication.
I mean, that's what the audience need to know. They think the BP has become normal means tablet is not required. How is that even? I mean, can you imagine the brain damage with these people?
Yes.
It's just incredible. 5 paisa tablets, Anil, some of them are 10 paisa tablet, correct? No?
I know. And easily available tablets everywhere.
And it takes you less than 5 seconds to pop it in, and still people are not doing this. It is such a tragedy.
I feel bad sometimes,
Yeah.
45-year-old gentleman was admitted recently. It's the same story again. Suddenly I had it. I didn't have anything. I don't have any medical problems. Then I said, when the last time
Exactly.
This is a common thing. I have been to hospital my whole life. So 45 years, when did you check your blood pressure? Never checked. Okay, assumed.
They said no BP. Then I have to ask, have you checked? Never checked.
Never
so
checked.
No BP, never checked doesn't mean no BP.
No BP. Yeah. So again, this program is not to scare the audience or something like that, but to be on the
No,
Safer said to
I will
precaution.
disagree with you. We have to scare the people because I'm telling you, if you don't scare the people, they don't take action.
True.
See, what you say from a child, "Benki kayak pada."
Yeah.
We have been brought up with that whole, the child has no fear.
Yes.
Only when you say that if you do this and don't, you see, don't invest here, you lose money. Then if you don't scare them, they'll put money, no?
Yeah, true.
So why
So
should...
we can educate them.
I mean, say I'll give you my own story. I'm a little straight in this, whether people like me or not. See, whenever I drive my car in the signals, I see a lot of people without helmets.
True.
And you know that, educated, intelligent people. So I would lower my window and say, "Yakappa helmet akila." And they actually take objection to mind your own business.
I would like to do the same thing. I thought I'll start a campaign, of in the Bangalore to keep Bangalore clean. So you see, it's a very common thing. They open the door, they spit. Okay.
Or throw.
And sometimes it's only a colorless spit. There will be colorful spits everywhere.
Correct.
Okay, so I thought I'll take this campaign of telling them. I had to hear a lot of things regarding my mom, my dad, this thing. Yeah. I hope you got it in their own their own languages. Colorful languages, and to mind my own business. Okay, so it was hardly 10 or 20% who actually took it seriously and said, okay, sorry. And then 80% the same thing. Mind your business, none of you.
No, and I'll take it to the next level. I don't know whether you saw yesterday, there was this Indian oil tanker caught fire in Jaipur or somewhere in Rajasthan. And some guy has caught fire. He's seeking help. And people are taking his videos. He died. Yeah. Why have our people become like this?
Sad. Very sad.
Why? They want somebody else to do the help. I mean, if there's one message, guys, we want to give from this video, be a better human being. You have to help people, because remember one thing, you never know when you or your family needs some help. So you never know when you are in an odd situation and things like that.
No, just one more and just we'll go to the next thing.
Sure.
When this COVID, all this thing have a cop, and everyone was wearing a mask. I was so happy that no one will spit now. But have a mask and other things. So I thought, I'm really disturbed. You just take your car and go out. They spit left and right. And best thing is, I think our people don't like white color, I guess. You see, they paint white, wait for a week or 2 weeks, it'll be red again.
Correct.
Those things. So I thought, at least on COVID, they know it comes through your droplets, etc. Nothing changed. COVID, everyone was scared, did a lot of things. COVID went, even that thing went. So now everyone is back to thing. Okay, requesting everyone to please follow all these things so that, we can make a better place to live. I think COVID times was really difficult times. A lot of challenges.
I agree.
I think if I remember rightly, COVID one was more of fear.
Correct.
People getting unfounded fear. Hospitals filling up, no beds available, and we felt hopeless at times where they call in midnight and there were no beds available. True. Only thing is, in first COVID there was so much of fear. Majority of admissions were not required.
Correct.
I think maybe, I don't know, it's my personal thing. Second wave, I think maybe we took it a little bit lightly, but we took, oh my God, so many catastrophes.
Yeah.
And the huge thing, bomb struck.
True.
As a neurosurgeon and neurologist.
I agree. But see, what we realized was, we, as being neuroscientists, we were not technically frontline.
Yes.
Though we were, giving a helping hand in a lot of places because of different reasons. But I think where we really got involved in the second wave, the peak of the second wave, is this so-called black fungus.
Oh.
And the black fungus is not black, but I don't know why it got the black fungus name, but it got the black fungus name. And the black fungus, though it was affecting here, what was our challenge was it going to the brain. Can you explain to us, our viewers, about black fungus in the brain and its consequences generally, and the particular case that both of us treated, high-risk case? Can you tell us about that?
Very interesting. Yeah. You know what? I met the other day. Let's start the story. First of all, these fungal infections are all opportunistic infections.
Okay.
We don't see it commonly in this thing. We see in only people who the immunity is compromised, who take steroids for a long time, who are suffering from kidney or a cancer, chemotherapy, or other immunodeficiency states. We see it. We don't see it. COVID, suddenly this came up. I think, I'm not a microbiologist. Black fungus, because I think it appears black on the microscope. Okay, whatever. It's called as mucormycosis.
Correct.
Usually, before COVID, we used to see in people who have uncontrolled diabetes mellitus.
Correct.
Okay, it starts with the nose, and if it don't treat, it goes to the brain, because what we call it's an angioinvasive too. It invades the vessel and causes. Oh, that case was particularly, I think, young software engineer was admitted in other hospital for COVID.
And
he improved.
Face black fungus.
and then he developed fungus in his sinuses, was treated, and then he had a seizures, unresponsive, and that time they referred to you and were admitted,
True,
and you,
true.
and we were shocked to see.
I agree.
Did you remember that
Yeah,
MRI image?
Of course,
Oh
I
my
remember.
God.
I forgot.
So
about that.
if you want to put it in layman terms, or this thing, it's almost 40 to 50% of the brain was invaded by the black fungus.
And the
What
two,
did
three
you do, sir,
abscesses,
with that?
2-3 abscesses in the brain,
Yes.
and you know that the black fungus in the brain had literally 100% mortality. That's what they were saying. 100%
Yes.
they were saying. And this guy, in fact, what was interesting was before he came, patient family came to me, and his brother-in-law was a criminal lawyer from Andhra Pradesh High Court. And he was like, very haughty and all of those things. And he had a bad experience, whatever experience he had there, COVID, nobody can have a pleasant experience anyway. He asked me, he was looking at me like this and said, how many cases like this have you done? So I had to break the jinx and make him a little more amenable to what is happening. I said, your brother-in-law's may be the first case. And I gave him a smile. So which is the truth, because the black fungus in the brain had just started. We have done other cases. So anyway, he had 2 abscesses in the brain apart from the general spread of that.
Huge ones, sir.
Yeah,
If you see
huge
the
ones, I agree. And too high risk to open and do. So I decided I do the special surgical stereotactic surgery. So I decided, let me tackle it stereotactically. Now, they were in 2 different directions. And everybody warned me, some of my colleagues who were there, this guy is high risk, he's a criminal lawyer, litigant, we put a case against you, you don't touch him. I didn't go. I said, see, we have become doctors.
COVID positive,
yes,
low immunity, you take all the precautions.
Yes, and 100% mortality. Why are you doing all of these things? See, but for me, somehow, I want to be a neurosurgeon from 8th standard. I love taking risks because at the end of the day, once we explain to family very well, I think there's nothing to lose at the end of the day. So I initially thought, listening to everybody, I'll only tap 1 abscess for diagnosis. But I was very smart. I planned the other one also through the same hole. I said, let me see if this full after 1 abscess is okay. It will do. And then as I went in, it looked okay. Then I changed direction, removed the other one, and the rest is history. Oh. And I heard you met him recently, many years later. What was that when you met him here?
No, I think we'll continue with your surgery. After your surgery was done, I think you came, you discussed with me, you told, Anil, I've removed majority of these things. We'll see. So, once they open the skull, do a surgery, it's not a good sight, And we repeat a scan and see, the bone is not there inside. The brain also is affected so much. And on the dominant side, the left side.
Correct.
So, but
he was very sick. He was very sick.
Very sick. He was in ICU for a long time. I think for some time he was on ventilator too.
Correct.
And then, but I think we had multiple discussions that time to how we can help him. This
it was new for us also.
Yes. Yeah. So, but I think we extensively read that time, and and good that they also stuck to us. Somehow they start believing us.
Correct.
The person who was in ICU ventilator
with
was not able to
mortality risk.
Yes, almost 100% mortality risk. COVID positive, and to add that he also developed high sugars because of whatever steroids given.
Correct.
Then 2 abscesses which was drained from there. And today, we'll just cut short. We treated him with whatever possible. The good thing is we never gave up.
Correct.
We never gave up. As you said, it was easy to put something and send him.
So 100%.
And that time there was no clarity about how long to give the antifungal agents and all those things. And this guy, whenever we repeat, the fungus is to come positive.
Correct. I remember that.
Went on for almost 6 to 8 months. And today, feels so happy.
I know.
Just a couple of days back, he has come to my OPD. Full shaven, full smart with his wife. And as you in my busy OPD, just sitting there, both are smiling, husband and wife. I could not recognize them.
Okay.
They said, they're from Andhra Pradesh. So, Telugu sir, he was asking in Telugu, did you recognize me? Oh my God, I was so happy, I'll tell you. That was an absolute.
No, I think so.
And good that you took that risk that day.
Correct.
And went ahead. And,
I agree. See, that's what.
And sometimes we should take the calculated risk.
I think so.
And very important, I think, is the family support. As you said, every time they come and ask you about this thing,
And we spend a lot of time with them. They see the effective communication, the patient explain to them.
That helped.
And especially when yet in the stressful situation of COVID, we were willing to do that. I think that made a difference.
I'm not critical about anything. Just imagine this patient shifted to another center. A patient came to us and stuck there, believed us.
True.
And sometimes that's what the message. I think you should believe your treating doctor.
Yes,
Once you know
yes.
they are good,
Trust.
they talk to you, trust the doctors.
Correct.
Most of the times, whatever may be the disease, you do well.
I agree. Well said. I agree with you completely.
And I should congratulate you. Well done surgery. And that you took the risk and, today's changed.
Yeah, sometimes
You don't believe the MRI today, except with a small scar in the brain is completely normal.
I haven't seen it. He came in once, I think a year and a half
I
back.
reduced all his medications. He was on
Fantastic,
minimal
fantastic.
tablets. That's
I'm
it.
so happy.
Back
Thank you
to
so
work.
much. Great. That's what the partnership is all about. The teamwork is very important. Each of us
True.
believing in the other team member. I think that also creates the magic.
Exactly.
Thanks for being such an able team member.
Thank you,
and
sir. Thank you.
that. And we have enjoyed a lot of such things
We had,
together.
I think, many stories to
I
share.
agree.
It's one of the
Another
stories.
2 hours it'll
Yes,
go on if we
yes,
talk
yes.
about all of
We'll
these
do
things.
it again.
Of course.
A lot of stories to share.
Of course, we'll do it
Thank
again. That's all. So coming back to mind your business. Because I think with improved acute care facilities, even in smaller cities now and towns now, patients are surviving, those who have died in the past.
Yes.
But the quality of survival becomes paramount. That's where what you mentioned, rehabilitation or neurorehabilitation is so important. Because, after the first few days, medically, there's nothing much that we will do except continuing the medicines. But reconnecting those damaged circuits, identifying them, knowing what is happening, and that's what you spoke about, neuroplasticity.
Yes.
Can you tell our audience what is neuroplasticity and what to look at it as?
Yeah. The stroke, I think we discussed till the blood thinners, post-lysis blood thinners. Now, what do you discharge and send them home? Look, I'll just give an example, okay? And a person comes to my hospital, get admitted, diagnosed stroke. I treat him with all these things. I examine him. He has no deficits, walking well, holding well, his daily activities are normal. I'll send him home.
Correct.
Okay. But he doesn't, but if he has a deficit like not able to write, he's not able to comb, he needs something for that.
Not able to speak.
Yeah, not able to speak. He's having imbalance to walk, not able to understand. Sometimes they're not able to get up from the bed. He definitely needs help. I won't send him home. Okay, I send him to a neuro rehab specialist.
This is like a coaching camp.
Yes. And where, like in simple, like some plants you cut and they grow again. So same, that's what the meaning of plasticity, the new networks develop inside the brain. So don't think that, there is a dead tissue and it won't come. It will grow. The surrounding tissues will sprout and grow. But if it sprouts in a proper environment, a proper stimulation.
Correct.
Like in a plant, we put water, manure for it to grow. We need some stimulation for the brain to grow. Brain always...
the plant also grows towards the sun.
Yes. Now, how does the network develop in an individual? By learning a lot of new things.
Correct.
Okay. So that we need to train that brain. Okay. For example, if I don't use the hand for 10 days, what happens to my hand? First, it becomes numb and then becomes tight and may I not be able to use it.
Correct.
But the signal goes telling that, Dr. Anil may not require the right hand, that it become a vestigial organ. Same thing happens here. So you keep stimulating the brain, it will grow. That is the part of
it's
the
like
rehabilitation.
If you don't use it, you lose it.
Wow, that's the thing. That's it.
Don't use it, you lose it.
Very important part of any stroke treatment. And I think it has developed so much. It's not just, when we were students, physiotherapy means exercise. No, it's not.
Shake a hand, shake a leg, pray to God.
That's it.
That's how it used to
That's
be.
it. No, that's not. It's a huge branch in
and
itself.
It's a science.
It's a science and multiple things in it.
Absolutely.
And,
very well said. Very
yes,
well
the
said.
person who has a memory issue is dealt separately.
Correct.
The person who has a speech problem is dealt separately. A person who doesn't know how to write, button, unbutton is dealt separately. Person who doesn't know to walk is dealt separately. And there's something called speech therapist, occupational therapist, physiotherapist. There's so many this thing. See, the whole thing comes back to put the person back to the society again.
Put him back into his community.
Society again. For example, I just now spoke that there was a taxi driver with the right hand. So this thing, we have to, who's the most important thing? The occupational therapist, to see how best he can use the right hand to put him back into this driving again.
Very well said.
So very important. This forms a comprehensive stroke treatment.
Yes, comprehensive is a part of stroke treatment. See, we have patients who say, you need, it's a physiotherapy marketing. Then I have to explain to them, there are 6 subjects in school: physics, chemistry, maths, biology, languages. Physiotherapy is physics. But you also have to do other subjects.
Yes.
Otherwise, you will not pass in the exam.
Pass.
The same way people say, a simple thing as exercise, we'll go to that. Do you do, exercise or something like that? No, they say, I do, what do they say? For back pain, because I just want, no, so I do walking every day. then I have to tell them, "Appa, if you brush your teeth, your face won't get clean."
True.
So the different parts of the body needs different
Yes,
attention to
yes.
make this happen. So you have not touched upon lifestyle habits, good habits. You did spoke a little bit of bad habits like alcohol and smoking and the fast food, but can you touch a little bit of how important lifestyle diet is in the day-to-day wellness and preventing stroke, for example?
I think most important, I think coming back to lifestyle, I think majority of the diseases can be prevented if you take your lifestyle properly. Your diet and lifestyle, very important. You need to have a balanced diet. One, obviously, it contains equal proportions of protein, carbohydrate, and fat. Eating right, one, and fitness. Fitness, whichever you like. So I always tell my patient, fitness is not a prescription. Like you should do which you like. There are so many ways. Nothing is inferior, no, superior, inferior. Some like going to gym and doing it. Some like doing swimming. Some like running. Some like jogging. Some like yoga. All these things. But you choose which suits you, which you like it. Okay.
Correct.
It's not that I do it for 10 days, the treatment course over. No. This is something which you have to carry with you.
Daily wages. It's like a daily wages business.
Yes, you need to carry on with you. So choose which you like it more.
Then
you be consistent with those
the chance of
things.
compliance becomes higher.
Yes.
The chance of compliance
With
becomes higher.
nowadays of the iPads, iPhone, sitting in front of this thing, online work, everything, physical inactivity, what happens? Sugars go up, your BP go up, you put on weight, and one more important thing, when you put on weight, I think this. I see a lot of patients now, what we call as OS, obstructive sleep apnea.
That's a good
Sleep is
point.
a very, very important thing. That's a part of your lifestyle thing. So we ignore sleep for a reason. It's the most important
Healthy
thing.
sleep, or what they call it, clean sleep. What is this? They call something. I forget the name.
Let's put it as a good sleep.
Good
Okay.
sleep.
So what is this good sleep means generally? Okay. So I always tell my patient, God has given 24 hours. So when they come to me, so you sleep for 8 hours, you do anything for other 16 hours. But 8 hours sleep is mandatory. I know it's difficult, but at least the 6 to 8 hours is what we call a good sleep. Thing. Is important because again, once you don't sleep, so to make my patient, I always tell, when the brain is when you're active, talking, brain is always working. Okay, it gets rest only when you sleep, and whatever small damages happen, repair work happens only in this. Sleep is the most important thing. We ignore it. So sleep hygiene, I think that's what you're looking at. That's more important.
That word was
okay, so go to bed
hygiene.
Almost on the same time. Avoid carrying all your gadgets to this thing. And some people snore while sleeping. Okay, I think this I lead to because this is emerging as one of the risk factors for stroke nowadays.
Correct.
What we call a sleep apnea or obstructive sleep apnea.
OSA.
If you are snoring a lot, and your partner or your family members tell you that you snore a lot, and in between you give a gap before you get your breath back, that is the severest form. Please go and see your doctor to get it right, because that's one of the risk factors again causing the stroke.
One of the ways for you to know that you are having OSA is you have daytime drowsiness.
Yes.
When you're falling, anywhere you're sitting, you start falling asleep because your sleep hygiene was poor. You don't get a restful sleep at night, and that's what happens. So I want to have a very interesting question. This is what we came from public poll when we did about this talk. Flu season, you have, summer, you have this GI, loose motion infection, or summer. Is a season for stroke, like people say, chalikala stroke, cold weather is stroke, hot weather, no stroke. Maybe in Ladakh there is stroke, or Kashmir, in Tamil Nadu it's too hot for stroke. Anything like that you have seen?
No, sir.
Nothing.
There is no seasonal variation in stroke. Okay. Yeah, there may be certain conditions where the vessels may constrict because of the cold weather, but that is only a very small proportion. It's not for the general population. If you persons who are suffering from certain rheumatological or immunological conditions, the weather may cause a problem. Otherwise, there will be no seasonal variation as far as I know causing the stroke cases.
So that means 24/7 by 365, you have to take care of yourself like daily wages business. Like how you manage everything else, your vehicle and everything else, you have to take care of your body every single day so that it runs well. We have covered a lot of stuff. I heard that you used to do some marathon running or this one before. Yes. So what got you? I see a lot of guys. Did you see recently there was a 35-year-old doctor who ran a marathon and died or something?
Yes.
So people think that because I'm running the marathon, I'm healthy. And that Omar Abdullah fellow, without in practicing, he ran to show. I mean, he was lucky, nothing happened. No, they set a wrong example. I have nothing against Omar Abdullah, but what I'm saying is, as public figures, They should be responsible to say, hey, he ran, I will also run. And what's your take on both why you did this and what is the risk factors and all of those things?
Yeah. As I told you, we need to have some fitness program which you like and which you're consistent at.
Correct.
Okay. Somehow I never liked going to the gyms. Okay. I'm going there and lifting weights or what. Then I think once my brother came to Bangalore and he took for a walk, morning walks, I felt so better. Then next day we went for a jog and the whole day was really good. And then I started doing 5K, 10K, 25K. And then
you're on 25K and all that, huh?
Yes, 21K, half marathon, sorry.
Whoa.
Okay, there is some marathon, we heard of Orville Marathon. Every year, February, it will be there.
I see.
I did 21K that time. But I did that after I practiced for almost 1 year. I didn't run 21K at 20.
Got it.
To run 5 kilometers a stretch, I took almost 6 months. Okay, I did extensive research on running and other things. I was also worried. Okay.
Correct.
Yes, I think in simple, I think my motto is everything in moderation is good. Okay, don't overdo it. Okay, even sugar in eye, this thing is a poison, what they say.
Absolutely.
So first condition yourself. Okay, like you go to a new place, you'll not be familiar. Body takes certain time to adapt to a new things which you say. So give enough time for the body and mind to adapt it, and then go for it. Okay, so it's not that he does 21K, I'll do 21K.
It's like become like a status symbol now, and he's running, I'm running, and then without checking what's going on, it's like trying to go to the moon on a cycle.
So the message is running is good, but overrunning is not good. In the sense, you need to know where to stop.
That's the most important. So now we'll switch. We have spoken a lot on arterial strokes. We spoke in the beginning, and there's something called venous strokes. So shall we speak to our audience on what is a venous stroke? Is there really some condition like that at all?
Yes.
And what kind of people are at risk? And can you tell us a little bit about that?
I think this is very important, especially in South India. I think the doctors...
South India?
Yes, it's a lot of venous strokes, what we see, it's more common in South India
really?
For some reason. Yes.
Whoa, I didn't know this.
I did my degree from NIMANS. We used to see a lot of venous strokes.
No, we saw, but I didn't know it was unique to South India.
More commoner here. See, if you go to West, the venous stroke, like what we call a cerebral venous thrombosis,
CVT.
What we call CVT is a common thing, what we see. It's not that,
Really?
Here we see almost one case every other week.
Yeah.
They hardly see any venous case in the West.
I didn't know this.
Even North India, there are cerebral venous thrombus cases. Definitely they see it.
Okay.
But I think it's for some reasons it's very common here.
Is it genetic? Is it weather? Environment?
There was a lot of studies and we could not pinpoint or something. Maybe weather, a little bit to do with the diet and other things. Okay. So as you said, the one vessel which carries the blood to an organ is called an artery. And if it blocked, what we have a classical paralysis stroke or something. The one vessel after the blood goes to organ, it has to come back to the heart. The one which gets it back is the vein. So that venous stroke. So same thing, the brain has a venous supply. Okay.
Correct.
There is again, because the brain is a big structure, I told this superficial and deep structures. Same thing. There is a superficial venous system, there is a deep venous system.
Well said.
The superficial venous system, they drain the blood from the cerebral hemispheres, surrounding structures. With the deep vein, they get from the deep structures.
Correct.
They come back to the jugular vein and back to the right heart, and it again recirculates, keep going. So the risk factors are different. And here, the common persons affected with cerebral venous thrombosis are the postpartum ladies, what we have seen initially.
What do you mean postpartum is post-delivery?
Post-delivery.
Got it.
Okay. That is one, what we commonly see here.
Correct.
Because a lot of hormonal change at the time. Okay. And few practices. I think now we try to educate. I don't know. Illi banantrik neer jasti kodalla. And they cover the whole
dehydrate
body.
them. They dehydrate this post-delivery.
There are certain practices where they believe that if you give more water to the postpartum lady, the lady who delivered, that the kid will have cold, etc. They don't give a lot of water. She is dehydrated.
I remember when my wife was in that situation, both the mothers was there. They said, what do you know? You may be a doctor. We are mothers that could,
She should have been forced to tie this thing on to cover her ears. She'll be covered with clothes. She'll be sweating. Not enough water. And third, they'll be breastfeeding. There'll be a lot of... So they'll be dehydrated. That's one of the risk factors, and a lot of hormonal changes. Second, this is people who take hormonal agents. Like oral contraceptive pills, they have this artificial hormone which given for certain purpose.
So you're saying, just to butt in here, is a lot of this young women having this is because of hormonal imbalance changes, and that's where the OCP
Yeah.
comes. Sorry, continue.
So the pills which has been prescribed for various reasons, so those hormones, they cause imbalance in the blood, they cause some endothelial inflammation, change the lipid metabolism, they cause a clot. So
And does this depend on how many days they take it? In the sense that the longer they take it, there, or it doesn't matter?
Both are true. I don't know whether there's something called as post-coital pill where there's a double dose given. We have seen many patients coming with thrombus after that, and
just one dose.
Yeah,
that's double dose, but one time.
Yeah, I think we have seen quite a few people, and not everyone on the OCPs develop the thrombosis, but certain
the risk is
risk factors. People who have, they develop with this thing. So whenever you are on a hormonal agent, and if you develop certain symptoms, please you have to think of venous stroke. Unlike the arterial stroke, venous strokes, there will be pain. And commonest symptom in a venous stroke mean, I'm talking about cerebral venous thrombosis, or what we call a CVT, is a short form. The headache is a predominant symptom. Okay. So if anyone is taking any hormonal supplements and you have headache, we all get headache. Like headache comes, goes.
Especially women are more common now. They keep on pushing under the carpet, pop some pill, and they keep going.
That's
around.
the problem. You see, a lot of headaches, migraine, all headaches are more common in women. True. So here again, women on pills, and they may confuse it for a migraine. They pop a pill and they can wait. But if the headache is continuous and there's some red flags, what we call, okay, severe unrelenting headache, severe vomitings, any visual disturbances, confusion, slurring, please think that you may be, and go see the doctor immediately.
Neurologist.
Neurologist, particularly, because they were the one who immediately diagnosed syndrome. The other risk factor of the venous strokes are alcoholism, binge alcohol. Suddenly there'll be parties. We have seen so many.
We saw during COVID, no? The longest queue was outside the damn bar store. Amazing. I tell you, priorities of people in life. We were worried about our patients. They were worried about their alcohol. I said, this is crazy.
There are quite number of young people who binge drink the
Correct.
Night.
Weekend especially.
Yeah, and they come back with, that's one of the thing. And severe dehydration can cause.
I think drinking dehydration is sort of connected also.
Thing. And people who have this fever, sweat a lot, they don't take enough fluids. These are the risk factors for the venous stroke. Here the important thing is, unlike the arterial stroke, here it's an outflow block, what we call. So the vessel gets blocked, and sometimes the vessel ruptures or they spill over, they have a bleeding inside the
back
brain.
Pressure.
So initial few days, there won't be a vessel, there will be only vessel blockage, there won't be any bleeding outside. There won't be outflow. They recover completely. Most of the CVT, cerebral venous thrombosis, they go out of the hospital without any deficits. Majority.
If diagnosed
earlier. So if you want me to put it in percentage, more than 90% of the patients we have seen, they're completely normal. They don't have any deficits. The difference here is, as I told you, it's outflow block. So the inflow is there. So there is no dead tissue here. The majority of the damage occurs when they come late. So what happens if there is water flowing into tank? This is how I explain to my patients when they ask what happened to me, why I had. You have a water tank here. The water flows. That's artery, and the vein goes away. What happens? This is normal. This gets blocked. What happened to the
pressure starts building up.
When the pressure builds up, you have a headache. Okay, that's where. If you go and see the doctor there, they'll open that blockage with medications and you're normal. If you don't go for a long time, it bursts. And that's how the bleeding happens in
the venous infarcts.
This thing, and they take longer time to recover.
But even then, they generally do better than ischemic strokes because the cell body is preserved.
There is no neuronal death compared to there. So they recover very well. One caution with the deep venous thrombosis, even if they come early, they completely recover. But if they come late, they are left with some deficits.
Correct. So deep venous thrombosis is not DVT that you commonly know, which happens in the leg. This is the deep venous system thrombosis that happens in the deep venous system of the brain. The funda is the same, the location is different. Keep that in mind. So one thing I want to add to the benefit of our audience is, you said about, oral contraceptive pills and all of those things. But there are a set of women who take this tablet to postpone their periods because we have this, whatever the Padati or whatever in Hindu, one that during puja time you should not be menstruating.
True.
So if that is due, the period is due.
Sometimes they want to travel to the hospital.
So they take off this. what we call as period postponing pill.
Yes.
And they think, yeah, he had more this 2-3 days, what's
True.
going to happen? And we have seen people in 2 days on
Yes.
that coming back with
Yes.
this. So what is your message, your take on this and your message to our audience on that particular thing?
As a
Especially the
neurologist,
women.
my answer is absolute no, don't do that. Because I have seen enough number of CVT cases, coming with all these things. Yes, but please discuss with your treating gynecologist about all these things. If possible, please avoid it.
I'll tell you a secret myself. I used to tell my mother, my wife, don't tell anybody, just go. Best.
Yes.
Halwa.
Yes.
I don't think God will feel bad. Let me be honest.
True.
So that's what I used to tell my wife.
It's a very good
don't
point,
tell
I
this.
think. Yeah.
I'm selling it only on TV. Okay, don't tell anybody this.
Valid point, sir.
So I think we had a great conversation, Anil. I think we spoke about arterial strokes, venous strokes, the risks. We didn't cover the surgery for stroke. That's another conversation for another thing. That's another big conversation. But I think we really covered, comprehensively what all our, global viewers need to know. So guys, if you have liked this video, you like the way we are giving you information, don't forget to subscribe to our channel. Don't forget to click the like button, share it, bell icon for sure, and subscribe to it. And also give the comments. We also want to know what more that you want to learn from us. We'll be more than happy to do it because we are here to serve you guys with more practical, actionable information that you can use on the ground to become healthier individuals. Because whatever PM Modi keeps talking about the demographic dividend of this country, we are the youngest country. We need to be the fittest also. We don't have to just be younger. Age is only a number.
True.
But we are seeing father waiting outside ICU for a son who's had a stroke. It is a very sad reality that is going on. So any last take-home messages you want to give our audience?
I would like to repeat, stroke is treatable, stroke is curable, and stroke is definitely preventable. So I would like to go externally. Almost 80% of strokes can be prevented if you can take care of your lifestyle, food, and any pre-existing conditions. One. And second, if you allow me, I would like to tell more in the sense, even after the stroke has occurred, please don't lose hope. Okay, majority of patients who come to me in a very, very bad shape, I think we have few in common. They're totally back into society now, normally, unless a little bit of deficits, but they're totally normal. The message is, yes, try to come to the hospital, to reach the hospital if at all you have any experience with the stroke. Even any of your family members or friends had a stroke, please talk to them, fill them with optimism. Stroke is nowadays, the treatment has changed rapidly. Don't you agree? 360 degrees.
I agree.
Okay, and whatever the stroke, what major stroke it is, with the available treatment and the rehabilitation technique, we can put them back into the society.
And one more to add to what Anil is saying is, a lot of our fellows go to Nati Vaidya. They don't even come to the hospital. They don't even get a scan done. They directly go to some alternate medicine, somebody in some corner. I'm not degrading anybody else, guys. You need a diagnosis first. Sometimes we have something called stroke mimics.
Yes.
It may be a subdural hematoma. It could be a brain tumor. It could be something else. So you have to first image. You have to have an evidence to know what is going on. And then we select the best treatment possible to get you the best possible outcome.
True.
Anil, it was fantastic talking to you. And as usual, you are so candid and you're so clear. I think it's a pleasure. We worked together for many, many years.
Yes.
I think, you've only gotten better from what I see. It's like
Thank you.
So
Thank you.
It's fantastic.
All your wishes and blessings, sir.
Thank you.
Thank you, sir. Thank you, sir. Thank you.
So we have a customary, just at the end of the program to give each of our guests this book that we have written on rebooting the brain. So you are no exception to that.
Thank you.
So
Thank you very much, sir.
A small gift from our side for rebooting the brain.
Mm-hmm.
So please do read it.
Sure.
Feedback of
definitely, sir. Definitely. Thank you. Thank you.
Welcome.